As far as I know, there's a number of absentees, but I think a couple of people said that they were coming in late, and there's some internet issues that I've been advised of. So
yeah, and there's quite a lot going on at the moment. So two of my non-executive colleagues, Michael has to just leave briefly to attend another trust meeting, and similarly Tom Quinn is at a meeting now, and he will be joining us in time for his item. So give my apologies for that, as it were. And before I do my introduction, perhaps we'll take apologies for absence first, if Julie. So I know we've got apologies from Laurie has apologised. Do we have any other apologies we've noted?
yes, Liz Sharp, Colin Hall, Amanda Cool, Nigel Robinson, and Matt Morris is having issues with his internet, but he might be in and out.
Okay, that's we as colleagues to note that, and just a formal welcome to everybody. Just to remind colleagues, this is a meeting in public, not a public meeting, but there is opportunity at the end of the meeting for members of the public to ask any questions relating to the agenda that is before us. Can I extend a particularly warm welcome to our newly elected governors who are attending their first meeting, and I'm sure they'll introduce themselves as they contribute to the meeting, but to give them absolute warm welcome and thank you for putting yourself forward to take on the role, and we look forward to your contributions over the coming period. And clearly we welcome any members of the public or staff or volunteer colleagues who have also joined us for the meeting. And before we press on with the business, perhaps I could just take a moment to reflect and thank the governors that have completed their term of office. They completed their term on the 28th of February, so it does feel a bit like the start of a new term, which is fairly unusual in early March. But we've got we've said farewell to Nikki Pointer, Chris Devereux, Harvey Nash, Marcia Martino, Waz Shakir, Nigel Wilmot-Coles, and Nev Kemp. They've all given a distinguished service to the council, and for which I know we are all grateful. They've all been written to, and they've received their CCAMP shields. I've had some very nice letters of acknowledgement from them, so they've all been, their service has been duly acknowledged in the time-honoured way by receipt of the CCAMP shield, which is a valuable memento of their time with us. And if I can ask colleagues who are not actively participating in the meeting, and when you're not speaking, could you please be on mute, just to preserve bandwidth as well and background noise. Right, I think that's the preliminaries underway. Apologies for absence. Are there any declarations of interest at all? Anyone got a pecuniary or other interest in the items being discussed? There's no conflict, as far as I'm aware. That's good, thank you. Can we move on to the minutes from the previous meeting? First of all, are they a true and accurate record? Those colleagues that were there, you're happy to say aye? Well, I'll take silence as assent. Okay, I'd see nobody objecting. Thank you. So the minutes are accurate. Now, in terms of the action log and matters arising, Julie.
There we go, just taking myself off mute. We have two outstanding actions. Just bear with me, I'll just share my screen. There we go. So the first action is with Tom Quinn and Laurie through their respective committees to consider data around the root cause of complaints. So as far as we understand that they picked that up through the WWC, but beyond that, they're not here to respond to that. So we'll move that on to the next meeting if it's okay.
Tom will be able to respond later. We just give him notice. I'm sure he'll be able to respond to that. And Subo, is there anything you could add from the Workforce Committee?
Just to say, Chair, that we did discuss this at WWC and we did do a deep dive into that. So there was quite a robust discussion at WWC subsequently.
Fine, that's great. Thank you. Thank you for that. And anything else, Julie?
receive update on a review of effectiveness of the Trust's internal and external communications, but Janine is on holiday, so she cannot speak to that.
Right. Philip, are you able to add anything?
I can't add anything to that, Chair. I'll have to come back to.
Well, we can take that forward as an action, and
yeah,
maybe we can take that offline as well, just to make sure you get a response on that. Okay, thank you. Any other action on anything else on matters arising at all, Julie?
No, sir.
Okay, thank you. Can we then move on to 6722, which is the Chief Executive's report, which is before you, and Chief Executive is present, correct? So, Philip, over to you.
Thank you very much, Chair, and good morning to everybody. Can I offer my thanks for joining to all our new governors, and I look forward to working with you over the term of your period, of your service. I'm not going to go through the report that I wrote. It's pretty self-explanatory, but what I will do is bring it up to date and cover a couple of other bits and pieces. So, starting with the just an update on the epidemic itself, because if a lot of the stuff on the news is that we're ignoring it, we're learning to live with it, and everything is returning to normal. That's not the case in the healthcare sector. Just in terms of what effect it has on us as an organisation, we've still got 200 staff off most days with COVID for some reason. Either confirmed or symptomatic. So it's still a significant addition to our abstractions. We are still, unlike the general public, testing routinely, and we have enough testing to make sure that individuals aren't having to pay their own testing, but we're supplying that now, and there's still, until the end of March, the opportunity to use the government website to get testing. In terms of isolation, we are still isolating if we're symptomatic, or and unlike the legal thing to do it, but our guidance is still very much that we should, so that we don't bring the disease unnecessarily into the workplace. So it's still having a significant effect on our business. We're still wearing PPE, which of course slows everything down that touch, but it's the right thing to do. The disease itself is abating slightly, but it's still very present across our patch, and with obviously a significant connection to kids going back to school when it spikes up and down. So what's our assessment? Our assessment is that there will be another wave, but at the moment what we're predicting is based on Omicron. But there is the signs of a new variant, and that the whole approach will depend on what the makeup of that new variant is, if it is the new variant. So it's not over is the message. In terms of our general operational performance and capability, our frontline crews and our EOCs and 111 continue to do an amazing job in very difficult circumstances, and I can't praise them enough. They've been working flat out for some time, and particularly in the call centres, the pace has been unrelenting. What's that led to? That's led to a bit of higher sickness than we would normally get, even if you exclude COVID sickness, the sickness is a bit higher than we would want, particularly in EOC and 111, and that's a combination of the COVID that I've already talked about, and then just general sickness, but with a particular focus on mental health. That we've got a lot of people off suffering from the symptoms of stress and anxiety disorder. I'm pleased to say our staff are taking lots of leave, so leave rates have been high, and even though that means that our abstractions are high, it means that people are getting some rest, and that's so important. But it does mean that we've still got an imbalance between the demand for our services and the availability of staff. It was a bit higher during half term, and that's normal. But and we're running at about 6% a day, short of crews on average this week. So that's roughly where we land. Our performance remains in the national. If you compare us against national pictures, across the 10 ambulance services, and the most important group of patients for us, probably the Cat 2 patients, so the very sick patients, and they're over 60% of our demand. So we're the third best in the country for Cat 2 performance, slightly worse about midway for Cat 1. Cat 3 is we're in the second quartile, and Cat 4 we're lower in the lower down the playing the list, but the numbers are absolutely tiny of Cat 4, so you know a very few make a big difference. So that's not a cause for celebration. Obviously, our performance should, you know, we're keeping some patients waiting far too long. And we're working really hard in the call centre, particularly in order to keep them safe. We've got really good systems for that, and I've seen those in operation recently. Nobody's letting up on that just because the pandemic seems to be moving away. In terms of what else is going on in the health systems, so all our health systems are really struggling. I've not seen, and I don't think anybody's seen, front end of the hospital performance struggling as much as it is now. All 4 of our ICSs, our integrated care systems, are on Opal 4, so that is their highest level of busyness, and essentially the hospitals are full, and that's causing several issues, one of which is very germane to us, and that is hospital handover delays. So they're still very present, particularly on the coast, and in the Sussex system at the moment. Kent has got slightly better, and Surrey is not normally the worst offenders, but we have but all of the hospitals are prone to delay at one stage or another. So it's not a specific place where we go. There's one hospital that stands out, and what I am pleased to say is that the days that we had to complain and for action to be taken are over, because the national focus on this is so strong. Every single leader in the health in our patch has had to come up with a plan to fix it, and that's being monitored by the NHS regions. So the focus on hospital handover delays has never been stronger. I have to say though, since that's been there for about 3 weeks now, and there hasn't been much improvement, and in fact it's slipped a bit. So great that the focus is there, but let's not think that it'll be solved overnight. In terms of other things that are going on, the CQC are inspecting us at the moment. So they have already been to our both EOCs, both 111 call centres. They've been to 3 of our ambulance stations, and we don't think there's any more being inspected. And then from on the 15th and 16th of this month, they will do what's called a well-led inspection, and that's more focused on leadership and how things are achieved, and how well we know our business and that sort of stuff. That will include a chance for a group of you to talk to the CQC as in a forum. You'll have a session on that this afternoon, and Giles Adams, who's leading that, will talk to you about how we're going to decide who joins that forum. But it's a great chance to help the trust, and he'll help you with how that goes and what to look out for. In terms of big projects, we're talking about Better by Design later, so I won't spoil the fun, and I'll cover that later. In terms of the big estates projects, we've got Medway and Banstead are the two big ones here, and both of those, I'm pleased to say, are largely on track. First people in towards the end of the year, and that's looking good. A couple of sad bits. Firstly, you'll see in my report the piece about a road traffic accident where Alice Clark was sadly killed. We buried Alice last week at some time, but it was a really meaningful and poignant day. Huge turnout from the emergency services, not only from us, but from London Ambulance Service, where she trained, and from the fire brigade, where her mother works. It was a fantastic occasion, but fantastically sad, of course, when you look at someone of that age having their life ended in such a tragic way. And the second thing that I noted in the report is that the 2 paramedics that were accused and found guilty of stealing drugs from patients were found guilty and were sentenced, and they've got good long sentences. And I'm really pleased about that, because the effect it's had on our paramedics. That one of their member one of their number could behave in such a way was extraordinary, and so I was really pleased that it was taken very seriously by the court. And I think, Chair, I'm going to then hand over for questions.
Thank you. And as well, for the press, we just asked colleagues to note our new Director of Nursing, Rob Nichols, is now in post, so your colleagues will come across Rob in due course. And also, just to say to our new colleagues who have joined us in the meeting today, hopefully we had the induction sessions and you've had our acronym buster, as it were. So if you're unsure about any terms used, please will you raise your hand and we'll clarify them for you. And the category, I think we've also explained to you around the category of our calls, category 1, 2, 3, and 4. So if there's any questions about that, please either ask them in the meeting or come back to us afterwards. We want to make sure that we don't blind you with say we're trying to keep things to plain English, but inevitably we will revert to NHS acronyms. So colleagues, any questions of the Chief Executive's report? It's full of, there's a lot in there. Some of which we'll cover later in the agenda under various items, particularly performance. But is there anything you wanted to clarify? And I see one question there. I think, is that Chris Gond, hi Chris, one of our non-executives. Hi Chris.
Good morning, Chair. Thank you very much.
Could you speak up, Chris?
Okay, can you hear me?
Just about. If you just raise your voice slightly, please.
Okay, thank you. I'll try and do that. Well, thank you, Chair, and thank you very much, Philip, for the report. It's just a quick question on your report, Philip. I mean, you talked about some of staff suffering from long COVID. Now, do you think, as you are predicting a third wave, how well do you think we're going to cope should the third wave arise, given the fact that we've got a large number of people on long COVID or COVID-related illness?
Let me just repeat the question, Chris, so to check that I've got it right. You wanted me to answer a question on how we're dealing with people with long COVID and what effect that has on us?
Correct, yes.
Yeah. Okay, so we've got 33 folk 33 folk with long COVID. 22 of those are in a position where they can't work. 11 of them just can't do frontline duties, and so we've given them alternative employment. And up until now, the regulations have been such that COVID can't be treated as towards sickness management policies. That has changed, and so now people with long COVID will be managed as per the long-term sickness policies. Those that are on alternative duties, we will have to look at over time, because some of them are doing jobs that we wouldn't otherwise need, but obviously they'll be dealt with in an incredibly sympathetic and structural way along with our policies.
If I just might clarify as well, as from a non-executive point of view, whilst it's an executive matter to deal with this and to manage and lead our staff and handle them in the appropriate way, from a non-executive point of view, clearly we will be working to ensure that through the Workforce Committee that we handle people in the most appropriate way, and we'll monitor that closely to make sure there is the needs of the organisation are balanced with the needs of the individual. So that will get attention from the non-executives as well. Any other questions at all regarding the Chief Executive's report? If not, Alison. Hello, Alison. Good morning.
Hi there. My question was, where are we on the mandatory vaccinations? Has that all gone away now?
Yeah, very good question. And for some reason, I didn't talk about it when I was doing the thing at the beginning. So you've picked up that very well. The mandatory vaccination hasn't quite gone away, because but we have been told not to fire anyone. So there are still some bits that that they're keeping their eye on, and the reason why it went away was because of the change of the change in the disease. So if the disease changes back to something that is much more virulent or much more dangerous, then it might come back. So one thing that we've got to do is we've got to try and keep persuading people to get vaccinated, but we're not going to fire them if they don't.
But if I may, from the board point of view, we will continue to encourage people to avail themselves of the vaccination. All the board have been vaccinated. We take a position very clearly on this as non-executives in particular, that we want to keep our patients safe as well as our staff. But we can't mandate. We have no power to compulsorily ensure people take up the vaccination. But that remains the organisation's stance, though, is one of positive encouragement to keep ourselves and patients safe. Thank you, Alison, for asking that question. So, see question, Andrew Latham.
Yes, thanks for your report, Philip. I'm just wondering whether you have had any feedback yet from the CQC and how you feel that the overall position will be at the end of the inspection period.
Andrew, Well, yes, we've had some feedback. It's been informal feedback, but from the people who led the various inspections. Obviously, the 111 inspectors are different than the 999 inspectors. So we've had 2 lots of feedback so far, it's been largely positive. They were absolutely clear in everywhere they went that our staff reacted really well, and they've engaged thoroughly, and it didn't feel like a tutored audience, spouting the company line. Everyone was free to say whatever they wanted, and so that was really good. And they said that made the inspection a very easy one to do. And what they do have to do is, if there's a red line issue, they have to tell us immediately, and there are no red line issues. So we know there's nothing disastrous, but I can't predict what they're actually going to write down, because we've all seen enough of these inspections that you get very positive verbal reports, and then when the written one comes through, it's completely different. So I can't judge how it's going to go.
Yeah, and if I may, it's not our place to, in the sense the CQC have a very clear methodology they work to, and subject to national verification. So any speculation at this stage, Andrew, would be speculation, and we have to await the formal response. But on a sort of organisational point of view, though, I'm very pleased the way the organisation responded.
Thanks very much. And
I think it shows a degree of professionalism, which I hope gets recognised in the report, but we have to wait and see.
Thanks very much, and all the best.
Nothing we can do. It's out of our control.
Thanks, Andrew.
Yeah. Matt Morris.
Yeah, thank you. So just to jump back to vaccines, VCOD, whatever we want to call it. One thing that I suppose would be useful, as it doesn't really get called out in the minutes of any of the committees that have been shared, would be understanding what the trust has done about quantifying that risk should it reappear, because we know that in the nicest way our friends in central government can do U-turns overnight sometimes. So the question is, have we quantified the risk to the organisation should the legislation stand and be reimposed, and what mechanisms has the board got in place to assure themselves that that is refreshed whilst it's a potential live issue?
Philly, do you want to initially respond? I might bring in Subo there from a workforce point of view. We have been watching this closely from the board in terms of
undoubtedly.
Yeah, you're right. So it's not an exact science, because some of the people that we don't, it's mostly where we don't know whether someone's vaccinated, rather than is refusing to be vaccinated. So there's still just over 70 was the last number I've got of staff that we don't know what their outcome is. There's 19 who are saying they're not going to be vaccinated. So the definite scale is 19, but there could be more in the other 60 that have decided but not told us. But that we think the scale is roughly where somewhere around 20.
Subo, is there anything you wanted to add at all?
But thanks, Philip. Thanks, Chair. I think that's the sort of numbers. I think from a WWC perspective, I mean, we have been keeping an eye on developments. And as you say, we don't know. The feeling at the moment is it's probably a deferral of a decision rather than a complete reversal. So we think that they will bring it in, but probably it'll be around September time. In terms of managing the risk, you've seen and heard about the numbers. I think we are looking at all the other opportunities to redeploy staff, including, I understand, redeploying them between trusts. So we do communicate and talk to and collaborate with other ambulance trusts as well to see whether there can be some sort of sharing of our resources in that way. Other than that, we just have to keep an eye on the numbers, which we think will be small going forward anyway, around about autumn time.
Thank you, Subo. I mean, just to conclude on that, the NHS has set up a clearinghouse as best we can, but it's a situation we're all desperately trying to avoid, though, because quite frankly, most NHS jobs, if there's a compulsory vaccination requirement, will require some elements of patient facing. So I think it potentially could still be a risk to NHS services, but we can't predict that at the moment, so we have to wait the government's next move. It's a matter of law, not something we can manage and seek day to day. And right, if I could, I think there's one more question there. I see Nick. Hi Nick, welcome back to the council.
Good morning, everyone. Hope you're well. It's a question for Philip, actually. In regard to the development, well, I'm particularly talking about Medway with the new Make Ready and Multi 111 and everything site. I know there's been a lot of discussion with the staff and there's been sort of good consultation, but there are a lot of worries. The main issue there is parking, like most of these new builds, and a lot of the people that are going to have to relocate are really concerned as to the level of this. I know there's been lots of work done on it and they've been looking at solutions because there's so many people going to be on site. Has there been any move forward on that as to finding a good solution to it?
So we have as much car parking as we're allowed to have, and it's more than than we've currently got in those 3 places where the staff are coming from. So we are confident that we've increased the car parking, but if everybody came in at the same time, there wouldn't be enough. But that's the case at every single station apart from one. So we're going to have to operationally manage that in some ways, and the ops staff are looking at how you do that by making sure you're not doing all your handovers at the same time. That's one thing. There's a park and ride that we will run for the first 3 months to see if there's take up, and if there's take up, then we'll if there's a requirement, we'll run that on past that. And then there's a variety of other sharing schemes and things like that, but I can't promise that everybody will be able to park in the base all the time, and I don't think we'll be in a place to do that ever.
And Nick, if I may, just to assure the council, obviously the council's job is to make sure that non-executives are cited on these issues and there are processes in place, both through the Workforce Committee and the Finance Committee, which oversees our building developments. This item has got visibility, and is something which we know from an informal point of view, we will do all we can to influence to make sure that there's fairness here. But I think also experience tells me this is never an easy situation to resolve when you relocate staff, particularly in relation to parking, which is an extremely emotive issue. But we are very aware of representations from staff, particularly around shift workers and access out of hours, etc. So we are all cited on this, and we'll support and work with the executives to make sure there's an equitable solution. But you can't please all the people all the time on this issue. But we know there are processes in place to try and resolve it properly.
Right. Good, thank you.
Thank you. Can I say one more question and then we will move on, if I may? I can see a hand raised. I'm not sure whose hand it is.
Stuart.
Stuart, hi Stuart, come in.
Hi, I work at Medway at the moment, and there's inefficient parking there at the moment anyway. We have to use either the adjacent roads, or at the moment we've got a compound, which was the old fire station, which we're allowed to use. And that's normally got about somewhere in the region of between 10 and 15 cars in from staff alone. With the ambulances as well, there's about 20 to 30 ambulances based out of Medway. I don't think there's going to be any sufficient parking at all, because you're going to lose a lot of spaces for ambulances alone. So that's one problem we'll have to look into really deeply.
Yeah, thanks, Stuart. Can you just note that? I'm sure there has been part of the planning, and all I can say, my admiration for the staff of Medway. Your current parking arrangements are very unsatisfactory, and the fact you have your cars vandalised on the street because you're not in a public car park, I have to say, you know, whatever we're doing has got to be an improvement on that. So let's make sure we don't lose the, you know, we keep the positives through this process as well, because what you've got now is very unsatisfactory, I have to say. And thank you for your professionalism in working through it. Right, can we move on to the next item, if we may, having taken the Chief Executive report? Moving on now to the our statutory duties, the membership recruitment and engagement report. Just bring in Brian Chester, Chair of the committee. Good morning, Brian.
Morning, Chair. Just a little warning, there's a lot of building work going on here, so while I'm speaking, if it starts, I'll speak louder, but hopefully we can get through it in the meantime. And for lots of reasons, it was unavoidable today. So, Membership Development Committee, I'm not going to go through the whole report as such, I'll take it as read, but suffice to say, it is open to all members of council, and I would encourage people to attend when they can. And it certainly helps when we actually have a consistent attendees in terms of continuity and everything else. The more we have, of course, the more ideas we actually get. It's been a difficult few years, actually, in terms of getting to our members of the public because of COVID, and we are now in a position to hopefully be able to move forward again. The plan of how we do it is there, and we still have the kit for governors who want to go out, and hopefully we can all actually manage to get out and about a lot more than we have actually, and both get in touch with potential members and members. You can see the numbers have fallen over the last couple of years. I think not as badly as they might have done in terms of what's been going on, and we're going to try and focus on the areas to improve representation, particularly in terms of disability. So it's all there in terms of the analysis, and I'm happy to take questions now on the MDC bit from anybody who wants to ask questions. And please don't be afraid if after the meeting, when you've had a second chance to read the report or whatever, that if you want to ask a question, feel free to email me.
Thank you, Brian. Helpful. Any questions, please, from the council with Brian's report?
Okay, so I'm afraid it's me again now, Chair, in the absence of a lead governor.
Chair, Martin Brand's hands up.
Sorry, I didn't see that, Martin.
Hi, thank you. I mean, just looking at the graph, there's a rapid increase, obviously, from inception up to it's about February 17, and then it starts to tail off before COVID comes along. I suppose, all right, there's a rapid recruitment phase, but is there anything magical about what happened in 2017 that changed the trend, which is un-COVID related?
Believe it or not, I wasn't around in 2017, so I can pass that one to Katie, but I'm not aware of anything magical that actually happened. Yeah. Katie, right. Do you want to comment?
So the focus from around that time was agreed on maintaining the numbers rather than rapidly increasing them. It costs quite a lot of money to do engagement with members, so we focused on quality rather than quantity. So we've just kind of kept them at a steady-ish number. It's not rapidly gone down. We've just held it around 10,000, 9,500 for a period of a few years. So that was the sort of reasoning as to why it stabilised. And the peak that you talk about was quite rightly, as you said, like we became a foundation trust. So we had foundation trust status, and you had to have X amount of members to gain that status. So that's why the rapid ascent was detailed in that graph. Does that sound okay?
Yeah. I mean, I just wondered if there was something to do with resource allocation, for example, because obviously, you know, you set up as a foundation trust, you've got to build a membership. It's kind of like an initiative that's of the moment, so to speak. And I just wondered whether or not there's anything to do with the resources that were put into the recruitment, because it just seems like a sort of sudden turnaround that was unrelated to COVID. And I just wondered whether there was anything in that, because I mean, if the objective is, if that was, for example, a factor, and the objective was to increase the membership, well, obviously then it's a question of priorities for the budget, isn't it?
Yeah, and I think, you know, it's a small team, well, a team of one in the membership office. So there is a point around resourcing, but it's a balance. I guess my role is divided up between supporting the council and also doing the membership work. So if, you know, if it was full-time membership, that might look slightly different. But like I said, just the agreed focus was on maintaining the numbers and getting good quality engagement with the members that we already have. And you'll see in the paper that Brian's just presented, our focus for this year is to attend sort of like large scale 999 events where we know there's lots of like engagement, people are interested in the service, and to try and sort of curate some interest in membership and perhaps standing as you guys did to be governors. But we're also looking at diversifying the membership and increasing representation, because we've seen a drop in patient voices within the organisation and the trust, so that's something that we're looking to develop. But I agree with everything you said, but just to give a bit of clarity on the foundation trust status and why it sped up and then why it levelled.
Okay, thank you.
I think it will, the fact when we can return to some wider events, I mean, I think we have been hampered in the last 2 years with unable to attend various trust hospital trust functions. For instance, was Katie was very diligent in attending, you know, out of hours, and we just have that, those opportunities just haven't been there, and we really need to. We will boost that as much as we can within available resources. Thank you. So moving on to the Governor Development Committee. I think Brian, you're taking the
Governor Development Committee report normally given by the lead governor, which we don't have at the moment. But again, we've already seen the influence of new council members in terms of the change to the timing of the pre-meet, etc. So it's always good to have new input. And again, just to encourage people that I think NDC and GDC are ways in which you can drop in and out of the meetings, ideally drop in more often, but actually that we can actually have influence on not only the membership, but actually helping to shape council policy. So again, the meetings that have taken place are fairly well documented, and the second issue within that, which I'll roll into one, is in terms of governor activity. And the main element of governor activity since the last meeting has been the attendance of new governors at an induction day, which was the 2nd of December. There's one error I note in the report that actually one old governor, that was me, turned up as well. So it was good to actually meet new colleagues face to face. And hopefully we'll get a lot more of that in place shortly as well. So again, I think the reports actually say what they are. I'm not quite sure when actually we've got we have shortly got an election scheduled for a new lead governor, which will again invigorate that. So any more questions on either of the two GDC matters?
No, I think, oh yes, there's what, Casey, a point of clarification. Casey, come in.
Super quick one, just to say that.
Can you speak up, Casey?
I know, I always forget to put this blimmin' mic down. Just a super quick one, so that we'll be looking at the lead governor, Julie and I will be looking at the lead governor and deputy lead governor elections for voting on around June time for the council meeting. We just wanted to give the new governors a couple of months to find their feet and get a grip of personalities and consider if they wanted to stand themselves. So it's coming.
Fine, thank you. Sorry, I meant to get in touch with Katie before the meeting to ask you that question. So, sorry.
Please look at your manifestos, colleagues. So we look forward to your number of people coming forward for an election. Thank you. Thank you.
That's it, Chair.
Thank you. And the governor activities and queries report. what was on the agenda, Brian? I think
government activities and queries. Basically, I rolled the one into the other, just saying that actually the governor activities are largely the induction for the new governors, which was beginning of December down in Brighton, and it was a good but not a full turnout, and we had a fair bit of input. You can also see in the report questions from Harvey, who and a response from Tom Quinn in terms of AACE. But I think that's all a matter of fact now, rather than actually anything that actually needs any further attention, unless, as I said, unless there are any further questions on it.
Okay. I think it shows the governors have been very active in holding the non-executives to account. So thank you for that and asking appropriate questions. So thank you for that scrutiny. Are there any questions on that report? We'll move on, if we may, to the next item, which is the assurance from the executive directors. We've got the integrated performance report before you, and we've got some various escalation reports from the committee on today's agenda, so we can pick up matters of assurance, but the integrated performance report is provided for your information. This is up to the end of December, and this is the one that was taken at the last formal board meeting at the end of January. So do the council have any questions on the data that's presented, the information that's presented there, that won't be taken up later on in the agenda on the escalation reports? So any different questions to ones you prepared for later for when we do the escalation? So it's a detailed report before you in terms of the trust performance. We're a publicly accountable body and we make sure we are accountable. So there's every detail of our activity here. Any questions at all? Are you happy to take that as read and we'll pick it up later? Oh, here's one there. Andrew?
My only question, Chair, is a technical one. This is to the end of December. We're now at the end of February. Would we not normally see more up-to-date data, considering the pressure the trust is under and the improvements that have been made? It would be useful to see that data.
Yeah, I think Howard has not yet joined the meeting. He will be joining us, I think, Howard Goodborn. But Philip, in terms of our reporting cycle of information, for board meetings, you have live data information you can access, but in terms of reporting to boards, is this the best we can do?
So there's a bit of up-to-date data in it when it's produced, but we all use the access of the live data systems, rather than produce reports out of time. Kirsty, you might have a better answer.
So this was raised at our pre-meet. So sorry for those that don't know me, I'm Kirsty Booth. I'm the new non-operational staff governor. Sorry, I forgot to introduce myself. Quite a few people already know me. It was discussed at our pre-meet, and I think what the council are doing, Andrew, is we're looking to probably amend the timing of where the council of governors is in line with the board, so that the data actually means something. So we'll move to meet closer to the board date, so that actually we're seeing the data in the time that the board are seeing it as well.
Thank you very much. I know that the trust, sorry, through the chair, I know that the trust has been working very hard to improve performance, and there's been a huge amount of work gone on. It's nice to see that improved performance coming through in the data, and December was a particularly difficult month, I think, for the trust.
Yeah, no, that well said, Andrew. But I think just in terms of our role, the council and the board, I mean, as the chair, what I can say to colleagues is that the executive have access to real-time data. I have to say, in my days of running hospitals, I'd have dreamed of the information we have available real time that Philip has on his iPad. In terms of we know where every ambulance is, we know every micro detail about our performance of what's going on around the southeast of England. When we get reports to the board though and the council is to look at trends. It's not the operational stuff is managed by Philip and the team. What we're getting to at the board meeting is to look at longer term trends and to assure ourselves the executive, are focused on daily performance, but also they too are monitoring the trends. And I see Howard is here, and Howard, I don't want to steal your thunder here. Have I explained our role there in terms of non-executives and the council in monitoring performance?
Yes, no, absolutely. I think it is relevant, the comment you make about what information is going elsewhere. So you're right and say, this is quite late for the governors to be seeing it. What I would say, for example, as Ned of the finance side of things, I do get to see the monthly financials on a much more regular basis when they're available. They are sent to me. Obviously, we have the finance committee meetings under a schedule. But so I'm comfortable that I'm getting to see that financial data in reasonable time frame. Obviously, always better to sooner rather than later, but I don't think it's a problem particularly for me. Performance point of view, yeah, we're always a little bit behind, but again, I think you have to ask the question, what would you do differently if you got the information earlier versus the cost of getting that earlier? I think it's probably, since you raise it, it's worthy of another look in terms of the timescale. But as I say, from a finance point of view, I don't have a particular issue in terms of what information I'm getting and the speed I'm getting it.
But we do, as non-executives, that we are alerted to. I mean, Philip and I have a regular conversation regarding performance, for instance, and I assure myself that with the executives and the trust leadership if there's a particular blip in our performance or issue, it is picked up both on a quality point of view as well as actual performance. So it's something which is actively monitored. But we've got to ensure, though, that we perhaps can compress the timetable without unnecessary expense, as it were, to make sure we're all up to date, because we rely on the governors, the members as well. You're ambassadors with the public, and we do rely on you as well to be up to date, or as up to date as you can be, to make sure you can explain to your members and to the public you meet, because it's important we keep explaining all the time, because our position can be misinterpreted, particularly in the media. So it's important we're all briefed. Okay, so we'll pick up more detailed matters later in the agenda regarding performance, but just ask colleagues to note the performance report, and we are looking at the reporting timetable to see if we can make it somewhat more real time. Moving on to the board assurance committees, item 7222. Howard's present as obviously his performance committee, so we'll take performance committee first. That's Howard, anything you wanted to share with the council, please?
Yeah, so first of all, I'll take the question that came through regarding performance committee escalation report. So just to repeat so everyone's familiar, the question was issues surrounding vernacular clarity or lack of context. What does the new care delivery model and what does that mean? Is it connected to better by design? So just addressing those points, yes, vernacular continues to be a challenge for ourselves, let alone yourselves. But yeah, there's a lot of acronyms used. I think if you haven't already seen a copy of the I think there's a list of the acronyms set out, it would be useful to get hold of that. Perhaps Katie could take an action to circulate that, because that will help, and there are a lot of them around the vernacular. But also, you're right, there is some language that gets used that becomes very particular to CCAM, and we'll try and elaborate as best we can on that. But it is a constant challenge. But having those abbreviations would be very useful, certainly for any new governors. The second part of the question, what is the new care delivery model? The new care delivery model is indeed connected to, it's a key part of Better by Design. And basically, what it's doing is taking a look from first principles, if you like, of how we deliver our service. So, ever since I've joined, even before COVID, we continued to have challenges in meeting the ARPs. We met them obviously a lot better than we did during COVID, but it was never very resilient. So even at the, regularly we would miss targets, even though we met them. Sometimes we missed them fairly regularly. So there was not that resilience that's necessary to meet those targets. And obviously during COVID, that's got even worse. So the question was, well, how are we going to address this? We keep getting this, and the answer we've come up with is, either you just throw more and more resource at it, but that is not financially available, if you like, because we're talking about probably, I think they've actually quantified it. It's moving probably an extra 500 or 600 people on the ground to deliver the service, to ensure resilience of the performance standards. That's a massive extra workforce that is financially just not achievable. So the plan was, as part of Better by Design, is to take a fundamental look at how we deliver the service and how we can make it more efficient, including, some of the key aspects of it are the hear and treat. Moving that from 9% to 14% means that we don't send out ambulances on a lot of services that we currently do, because with clinician input, and that's part of it, is having extra clinician input, we push up that hear and treat percentage as an example of the care delivery model. So it's really throwing everything up in the air and saying, well, how best should we just have a look at this? Also looking at other ambulance services and looking at the best performers and seeing what they're doing in the different areas, and yeah, taking a look at that and how we can best deliver the model going forward, which is all critical part of Better by Design. So in addition to that, and that is necessarily a longer term objective, in doing that, it's clearly not an easy short term thing. And so for the program is now well developed and either launched or about to be launched. And but it's not going to deliver all the changes that we need for 22-23. So we have to, in parallel, have a sort of shorter term strategy in the form of the performance improvement plan, looking at specifics of what we can do in the meanwhile, whilst we get our longer term plan. So it's a two-pronged approach. It's the short term performance improvement plan, but also this much longer term Better by Design project, including the operating model. So that's really the background or the answer to that question, if that's okay. And then in terms of other things on the performance committee, so we had one on the 6th of January and we've just had one earlier in the week. I think just going through the escalation report, key items, obviously the integrated plan for 22-23, there's been some huge improvements here in the process behind the planning, albeit, as I say, that obviously in terms of the actual delivery of the service is going to be necessarily based on what we've got at the moment, slightly improved rather than full Better by Design, because it's not developed yet. Having said that, the integrated plan, the process, there has David, our new director, has done a tremendous job in terms of delivering a new planning process. So that's really, really helpful, and being able to model CCAM going forward. So that's a huge improvement. In terms of the performance management overview, we gave partial assurance simply because of the fact that we're not meeting the ambulance performance targets. Although having said that, as was mentioned earlier, we do compare relatively well with the other ambulance trusts. Certainly through December and January, on category 2 in particular, we were doing pretty well relative to the others, and certainly mid-table for a number of the other categories. So we're not out of line. We're doing pretty well relatively, but it's partial assurance because we are not meeting the targets. So we have to accept that that is the case. And even with the short-term improvement plan, we're going to be continually challenged, as we have been, until I think we get our handle on this improved delivery model, which will hopefully improve substantially the efficiency and, as I say, hear and treat, for example. The other areas covered were the additional funding for the winter monies, which has gone well, but the executive are now paying attention to whether those winter monies can, which were one-off, can continue into the future, because they were key in delivering some of the improvements, certainly on the phone lines in particular, which also incidentally has improved significantly directly as a result of those winter monies. So the medical assistants in the call centre have increased in number and enabled us to perform relatively, again, very well on that front. I think that was mainly it. The main points I wanted to raise on the performance report, unless anybody's got any questions.
Thank you, Howard. That's very, very detailed. And just for new members of the committee, this is the performance committee is relatively new. We're in our initial first meetings. We wanted to bring more focus at board level on the question of performance, which Howard and the performance committee now bring, without getting involved in the day-to-day arrangements. We do have more real-time monitoring now of what's happening from a non-executive point of view, and I think from a board, I think we're able to give more assurance now regarding how we're meeting various national targets as well as our own. So let's take some questions. So Martin, I think you were first with your hand up.
Oh, there we go. So you mentioned about 500 to 600 people to actually provide the performance that's ideal. Against the current establishment, what's the number of staff vacancies?
Against the
current authorised establishment, I mean, we're presumably not at 100%, are we?
We're not at 100% now. I think about, in terms of hours, I think it's about 90%. So it's about 2,400 people we've got on the ground and in the front line, and on an equivalent basis to deliver this service with resilience, they estimate about 3,000, just over 3,000.
And Martin, that's the reason, that's the reason why we have the Better by Design process now being developed, and we've got a specific item on that, is how do we manage that gap going forward. As Howard has said in his introduction, it isn't just a question of going cap in hand asking for more money, because the money isn't there and the workforce isn't there. So we have to find ways of doing things in a better, more productive way, and that's what Better by Design's about, and the Chief Executive will take us through that later.
Yeah. So can I just clarify? I appreciate that that's the ideal. Mine wasn't against what you might call the ideal world. It's clearly, I mean, in your budget for this year, there'll be a certain number of WTEs, for example. I mean, I can only speak based on my experience in London, but we were about 300 people short of what we actually had budget for, let alone the number of people that we'd ideally have over and above that. Because the fundamental issue in London wasn't so much the money as the shortage of the staff. So it was, the number I was looking at was more what you've got money for now, rather than what you'd ideally have money for in the future.
Yeah, good point.
Yeah.
Thanks for
yeah, I think we have both problems. So we have a shortage against what we need. Perhaps Philip can elaborate further. Against our current budgets, there are vacancies, absolutely. I don't think it's quite that same sort of proportion, but we still certainly have that problem. But yeah, so we recognise filling this gap. It would be a major problem, as well as actually having the funding to do it. You're right, it's twofold. One is, I don't think we'd ever get the money, and even if we did, we recognise we would never be able to fill it because of the availability of staff. Philip, do you want to comment?
Yeah, thanks, Hannah. Great question, Martin. We budgeted this year for 2413, and we are below that, but but we are exactly where we planned to be in terms of numbers, give or take. And the way in which, and I'm sure you'll understand this, but the way in which you can make up the difference between your budgeted number and the staff available, if you can't get to the full number, is by using private providers, by using overtime, by using bank, etc., etc., etc. So you fill the gaps with those. So with sensible assumptions about how much overtime, because of course you can't get unending overtime, and it wouldn't be safe for you to do so because people get overtired. You can make up that difference, and that's how we got to the point where we were in the balance of what we've been budgeted for, and what we've been funded for. But we do need more each year, and Howard's exactly right in that there's the two issues. If someone suddenly gave us 30 million, which is roughly what we're short of in terms of funding to get to that number, we couldn't recruit those staff next year. We could recruit them over a 5-year period, so it would have to be a slow build up, and we'd still continue. We've been on that build up for since we got the last income rise, which was 2017 or 18.
Thank you, Vote. Any other questions relating to the Performance Committee report? Okay. Ask colleagues to note that, but that's one that does, obviously it's an very important item. Moving forward to the Workforce and Wellbeing Committee. Sula, I think you're going to introduce this. Thank you for stepping in.
Lovely. Thank you, Chair. Yes, I have received some of the questions as well, and thank you for those. I'm always delighted to get really searching questions on WWC, so I'll try and answer them as best I can. I'm not as brilliant as Laurie, so forgive me for the substandard presentation. So you wanted some background really on the context and narrative surrounding the current challenges for workforce and wellbeing. So you've heard already, I think, some of the general challenges around staff resourcing. So increased sickness, people taking annual leave, which we want them to, but of course that's a challenge. And of course we have high vacancy as well. So combined, that gives us a challenge across the piece around staff resourcing. Against the context and background of increasing hospital handover times and less than 10% on hear and treat, but we are still managing to get very good outcomes on clinical outcomes for our 111 service. So that's some of the background in terms of what we are looking at. And in terms of well-being, and I think there's a question further down around the provision of our hub, our mental health and wellbeing hub as well, and whether it's valued by our staff and by management. I can assure you that it certainly is valued very much by both staff and management, and we know it's a very important part of provision for staff on the front line and back office as well. And of course, we are undertaking a review of our mental health and wellbeing offer, and looking both for value for money as well as is it actually effective, is it meeting the needs? And we're looking forward to seeing the outcome of that review at the next WWC. I think you also asked a question around our concerns, if the board has any concerns around the low level of completion of staff appraisals, and what additional assurance has been undertaken to understand the potential issues around the low completion rates. So we have expressed this, I think, on a number of occasions around the completion rates for appraisals. We know it's low. There are some challenges there, not least because of the pandemic, but also because of our staffing and how we need to meet REAP4 requirements. And again, we are assured that there is some changes being made to the appraisal system to make that more effective, and so that we actually do get something positive out of it and the staff feel that they're having a very effective appraisal. But equally, there might be some changes in terms of the timing of the appraisal system, whether it is more appropriate to do it after each staff member completes their year in, rather than everybody doing it at the same moment in time. So again, that is also being explored to see whether that will have a more positive impact on the completion rates. You asked also a very interesting question around a worrying trend around paramedics making moves towards GP practices. And yes, I can assure you that is certainly on our radar. And the truth is the primary care networks, which are the conglomerates of GP practices coming together and starting to recruit paramedics into those clumps, as it were. They can offer them some, regularized hours, higher salaries, all sorts of terms and conditions that are very attractive. And it's very difficult for us to compete with that. But of course, one of the key things that we want to do is then look at career development for our own staff and how we do that. And that is why the clinical education strategy is so important to that, so that we can develop a very clear career framework and support our staff to move forward within the organisation, so we can actually retain those that really can see how they can progress through the organisation. So that's one of the ways that we'd like to compete, but we acknowledge that there is a real challenge there in competing with PCNs and the GP practices, but we will continue to try and make ourselves an employer of choice as far as we can. You then talked a little bit and asked a question on the year-on-year increase and the national campaign around violence against frontline staff and what assurances we have received around appropriate internal actions to protect staff. So this did come up at the last WWC, and I note that perhaps the minutes for the last WWC in February haven't been circulated yet, but you'll find much more detail in those minutes. So, welcome further questions once perhaps you've had a chance to read those. But one of the questions we did ask specifically around this was what else we could do in addition to the body-worn cameras. And we talked a little bit about de-escalation training for staff, so to equip them really, to support them, that they have more than just the camera whilst we are going through the trial and we assess how effective those cameras are. So that de-escalation training is in train as an additional measure to support our staff, but also to give them confidence when they're out there on the front line. I've already talked about the health and wellbeing review, that we would like to look at that. And I think Philip has already given some detail on the long COVID and our plans on that. I think Philip has also given you some detail on the mandatory vaccines situation and what we plan to do on that. As far as the 100 new CFRs are concerned, I'm afraid I will probably have to ask my executive colleagues to come back to you on the detail of that. I don't know any further detail on the numbers. In terms of workforce planning, one of the things that you talked about in terms of overarching numbers, and Howard has already talked to you about the gap, that's one of the reasons why both at Performance Committee and at WWC we have pushed to really move forward on an overarching workforce plan. And if we can get to a 5-year workforce plan, that would be really helpful. So we are making great strides on that and getting much more sophisticated data that is giving us real insight into what is the current situation, what is the future situation, and what might the possible scenarios be. So that's really helpful for us in planning going forward. I think that's probably it in terms of the questions, unless there's any further questions.
Thank you indeed, Subo. Colleagues, there's a question, Matt?
Yeah. So on the staff element and the fact that you said there's.
Can you speak up, Matt, please?
I've got issues with my connection today. I do apologise. So my question was follow up to the staff safety element and the de-escalation training, and the question was really around whether there was other assurance activities in that space that were already in flight, or whether there was other questions. Because, for example, I know that some trusts are looking at public campaigns around that. I know that we've got the national campaigns ongoing at the moment, but the longevity of actually doing localised campaigns around staff safety, and the fact that staff are, of course, important to the patient's care and so on and so forth. Is there any other things in that space, or is that stuff that would just come out in the minutes that you've mentioned that we will get eventually?
Matt, thank you. That's a really interesting question. I don't have off the top of my head any further detail on that. I don't know if any of my executive colleagues do either.
Thank you. I think, Philip, I think there has been. I think you were quoted on Look South East the other evening on this matter. So from the health correspondents, in terms of some of the actions that CCAM have taken recently. So just to act as your warm-up act there, Philip, what else are we doing?
Yeah, one of the big ones is something called OpCavel, which is a way of getting the police involved more quickly. So and more definitively, and because the best thing we can do is get people sent to prison for doing it, and then publicise that. Us going on saying please don't assault our staff has a limited effect. So the national campaign is important. It had the resources to do things really well, and that works. We'll continue working with the local police and with our local stuff. But the other thing I'm hoping is we're going to do some filming about the PRU. Which is the Joint Response Unit. This is in urban areas where we share transport with police officers. There's going to be a fly on the wall documentary about that. They're starting to film quite soon, and in there, that's a good way of getting that sort of message, because it hits the right audience profile. So we're doing things like that as well, but.
Thank you. Just need to pick up the pace. Anything else, Philip? Sorry.
No, but I did notice that there was another hand up trying to answer that question, but it's gone down. So don't worry.
I think that was me.
Yeah, it was you, Tom.
Hi, Tom.
Thank you. Morning, everybody. Apologies, I'm late. I've been being grilled in preparation for CQC this morning. Can I just come in on the well-being aspect, just so that Governor colleagues understand? So. The NHS People Plan asked for the establishment of well-being guardians in each trust, and that's a non-exec role, and I take that role for this trust. And I'm working very closely with Ali as HR director and with non-executive colleagues across the South East region on how we work together to safeguard, if you will, the health and well-being of all the people who work in the NHS from top to bottom. And only yesterday there was a request from the chairman of North West Ambulance Service, who is the wellbeing guardian for his trust, that all the ambulance wellbeing guardians get together to share how we're going about this and to learn from one another. And I'm quite happy to come back with some progress reports on that in due course, about how we can learn together how best to improve the lot of all our NHS staff, really.
Thank you, Tom. I'm sure the staff will take, the staff governors note that and take assurance back to the staff that Tom is actively involved in this space, because it's something which the board does take very seriously. We do want to protect our staff. Can we also, are there any other further questions of Subo regarding the workforce reports? Can I also now take the governor observation report? Then I'll go back and just take the observation report for the performance committee, which I mistakenly overlooked. So the governor observation
Chair, forgive me for interrupting, but there is one question from Lee Westwood.
Hi, Lee. Sorry, I couldn't see you on my list.
No problem at all. So Lee Westwood at Lower East Public Governor. It was good to hear, because it was discussed in our meeting about the de-escalation training. So it's good to hear that that's on the radar. But it would also be good to just get assurance that whilst it's on the radar, it is including the volunteer side as well, because obviously there's an impact on cost and resource.
Absolutely, Lee, and we did discuss explicitly around volunteers and how we support them. Forgive me, I can't remember all the numbers from it, but I do know that it's captured in the minutes of our last meeting because that came up as a very specific item. So we do have assurance that the volunteers are included and an important consideration for us in that as well.
Thank you for the question. Tom, can you give some additional assurance here?
I can, and Emma, of course, our Director of Operations, did provide some assurance on this. The situational awareness training that everybody will have before they go out patient-facing does provide a measure of protection. So whilst we are yet to fully roll out the de-escalation training, Emma did, because I was worried that we hadn't got that rolled out. And indeed, I called it a red flag at our meeting. Emma was able to very effectively provide some reassurance that some of the existing preparation you have before you go out around situational awareness can certainly help to reduce the risk of conflicts and violence.
Okay, thank you, Tom. That's very helpful. Can we conclude on the workforce report? Can we now move on to just take the Governor Observation Report? That's before you. So I'll come back to the Performance Committee in a moment. Governor Observation Report, you happy to receive that, or does anybody want to add anything to it? Suitably positive for a report, I think. And simply just to remind colleagues, we've got the work, and also I overlooked it, the Performance Committee Governor Observation Report as well. So no more questions on that. So I'll just ask my non-exec directors to kindly note the contents of that report, and clearly what you're doing is appreciated by our governors. We'll take it as read. Okay, thank you. Let's move on now to quality and patient safety. Now, Tom is we're going to do the deep dive a little bit later in the meeting, so the minutes are there for you to, the reports are there for you to receive. Is there anything, Tom, you can cover now that you're going to cover most of this in your report later? Is there anything else you want to say now at all?
No, I think we'll keep it for the deep dive, David. Thank you.
Okay, thank you. So the colleagues can hold their questions till then. And in terms of the Governor Observation Report, that's also there. Can we take that as read? So thank you for your feedback. The Finance and Investment Committee, Howard.
Hi, sorry, thank you, Chair. Right, again, I'll start with the questions that have come through regarding Finance and Investment Committee. There's a few of them. So the first one I've got is, how is the Trust looking forward in terms of planning arrangements, understanding that contracts commissioning is changing throughout the NHS? I think the main sort of thrust seems to be that the system control total being in balance overall seems to be at the core of what they're trying to do, which means they're less worried about the individual parts of the system than they are about the overall ICS position, which of course is not particularly helpful for us being a foundation trust part of the system if we're in deficit. So there is a bit of a conflict there. They're sort of saying it's all fine and dandy at the overall control total, even though they've got challenges, but don't worry if you're in deficit, because it's fine overall. And that's certainly been the case this year. But you know, that does present us with a challenge, particularly as you know, we are in deficit this year. Our latest forecast is a deficit of about 9.6 million. And that's why, you know, Philip and David are going into bat on the negotiation front for the forthcoming years. So although we can probably afford to take that on the nose this year, going forward, and the number gets bigger still, is a challenge for us financially, because we can't just take those deficits without it fundamentally affecting our financial standing, if you like, going forward. So the integrated planning, and by integrated I mean integrated with the ICS, is well underway, and we're working closely with the lead commissioner, Surrey, who represents the four ICSs we serve, and that's going okay. But obviously there is an important negotiation going on, but I think we've got the right resources devoted to that negotiation. The second question is regarding the CIPs, that's the cost improvement plans, around the assurance cost improvements of 1.7 million against the 4.4 million pound target. And there is indeed a backloading, if you like, in terms of achieving those savings. So two points I'd make. One is it's remarkably easy to forget where we were sitting probably about a year or so ago, 9 months ago, in terms of COVID and the challenges we were facing. And frankly, cost reduction didn't feature highly in those times. And so there was a conscious relaxation, if you like, not to drive efficiencies during those very difficult times. However, having said that, what I can say is that our current forecasts actually, if you like, fill the gap. So we're not expected, our latest figures do not fill that gap, even with the backloading, with cost improvement plans as you would expect them. However, they are filled by other savings. The problem with that is that those other savings are not necessarily recurrent, and that's the key to efficiency saving, is that it becomes recurrent into the following year. So this, although we are going to be able to meet the shortfall this year by, as I say, various savings and unused reserves, what we can't do is then, that just creates a challenge for next year, a further challenge. But we are able to meet. So within the forecast, just to be clear, we are still planning to meet the forecast as originally envisaged, despite that shortfall on the cost improvement plans. The next question was around inflation. It's a good question, but I'm not quite sure what we can do about it, because it's all set nationally. We can go back and argue the case, but inflation on our income is set nationally as part of the contracting allocations from the centre, and likewise pay inflation by and large, by vast majority, is settled under the Agenda for Change and national pay settlements. So we don't really have a big input into that. We just have to take on board those, and any gap will form part of the any gap with the income negotiations with the lead commissioners. So a difficult one, but a good question, but I'm not quite sure. Obviously, to the extent that it relates to other non-pay, so pay represents very broadly about 80% of our total cost base. In terms of the others, we can look at those. Most of those contracts, I believe, are fixed price. So there's multiple year contracts, they'll be fixed price. However, given the size of the change in increase in inflation, I would not be at all surprised if a number of those suppliers came back and wanting to renegotiate those contracts because of that gap that they're being asked to absorb being way too high. So that will be another pressure, but it's a smaller pressure. Question I've got as D. Would like to know what significant changes that are needed in the trust approach to efficiency savings actually means. I think there are two angles to this. One is just a very specific point. The executive wanted to rebrand the sort of cost improvement plans to an efficiency. So moving away from cost cuts to something that is more around efficiency, working smarter, working leaner. And that was just a specific rebranding of that into efficiency savings rather than cost cuts. That was the minor point. The bigger point around the significant changes to efficiency savings is better by design. So again, as I mentioned earlier on, a real drains up look at how we deliver the service. That's what I meant about, or was meant by the other aspect of this efficiency saving. Significant changes. And then the other question is a big one, and seems to be a remarkably emotive one around the fleet, and specifically the issues on the Fiat. I think I will defer to Philip in a moment on it, because I know he's very close to it, but there are a few points I would like to say on this. First of all, strategically, these Fiats are a national specification in compliance with the Carter Review. So it's not like we've gone away and done our own procurement of some odd vehicles. It is a national specification, and there are two, I think, the Mercedes and the Fiat. In terms of that as a principle, reducing the variability in the nature of the fleet makes huge sense from my perspective, both from a management, maintenance and cost perspective. That clearly makes sense to reduce to that. We're not quite sure why London Ambulance Service managed to exclude itself from the procurement of Fiats. I don't know, maybe Martin or somebody might be able to enlighten us on that. But they are the only, as I understand it, they are the only the only ambulance service who have seemingly excluded themselves from the procurement of Fiats. So all the other ones are procuring in line with the Carter Review. The other aspect of this, of course, if we were to then go down to, as an industry, to a single supplier, you can be absolutely sure that we will get screwed if we do that, because all that will happen is you'll go down to one supplier and they will then put up their prices and we'll have no alternative, and we'll get screwed. So having a second supplier is commercially critically important, that we have that availability to go to someone else if they start being silly and putting up their prices. So it's important that we have them, and Fiat as so strategically, I think this is absolutely the right thing to do. The other point to say is that there is no question, I think there were questions around legality. There is no, how many Fiat vehicles require attention due to their seat belts, and are they still in daily use? If so, why? As far as I'm aware, driving a vehicle with faulty or ill-fitting seat belts is illegal. Okay, so there is no illegality in what's going on here. Fiat would simply not be able to sell their vehicles if they were illegal, they did not comply. So that's off the table. The issue is the suitability for any of these vehicles for some proportion is normal. Up to 5% is normal for outsized people. I think in this case it's mainly tall people. Is not necessarily ideal for the situation, and hence why we've gone down the route of getting these self-declared assessments. So where we've had the problem, what we, as I understand it, and again Philip will elaborate, where we've had the problem, and I certainly don't, I've not come across this fact that up to 70% of 1OU are unable to drive the Fiats. I find that quite difficult to believe, but if that's the case, where we have had the problem, where people genuinely do not fit in the seat belts, do not fit them very well because they're too tall, it goes across their arm rather than their shoulder, I think, then we have rebalanced the portfolio of vehicles to put Mercedes across, where suitable. But in parallel, we're also doing some work with Fiat and their suppliers to try and reduce the problem further. But fundamentally, there is a problem, but it's for a small proportion. The other final point to say is that for some reason this does seem to be an issue that affects us and nobody else. So I think we need to, I would say nobody else, I mean, it certainly only affects us significantly. For some reason, it's not clear why that is the case, but certainly the other trusts who use the Fiats do not have a problem anything like the scale that we have. So it does raise a question in my mind about whether this is the problem or there's some other problem. It seems unlikely that we've got a higher proportion of tall people, but I suppose anything's possible. Okay, with that further ado, I'll hand over to Philip.
Sorry, Chair, can I suggest that there's some hands gone up during that conversation? If those are on Fiats, let's get the questions out, and then I'll try and deal with them all at once.
Yeah, I'm just reminding people, Phil, as well, we're up against time here, and our purpose of the council is to ensure the non-executives are aware of, are assured about issues that are currently happening in the trust. So I don't want to reopen the whole Fiat debate here, because this is not the place to have that discussion. This is an executive matter. What we need to ensure in the council is, are the non-executives aware of the issues, and are they ensuring the management to handle the process, and our staff are being treated fairly? That's where we need to get to, rather than debate the merits of Fiat. But anyway, in terms of questions, let's take some media questions, like short, sharp questions, please, to keep time. Can I take you first, Kirsty?
Yeah, mine is literally, what I would just like is for those areas where there are more, and Howard, you have just alluded to it actually, so we have moved the fleet around where there are more issues, and that's really good to know. But I'd just like to be assured that as the non-exec directors, that we are making sure that any instance where a staff member turns up on duty and they can't, because it's a Fiat, they can't then drive it, of the patient safety impact, we need to be monitoring that if we're not already. I can't imagine that we're not, but I can't believe that there isn't a patient safety impact at some point from this. No, and you've kind of settled my mind saying about the fact that we've moved fleet, but I still think that we need to probably look at that to see whether that is an issue.
Okay.
That's on the mind.
Thanks, Kirsty. We'll just hold that for a moment, and then we can group the questions together. Thank you. You make a note of that, Philip. David? David Romaini?
Yeah, hello, David Romaini. I'm a new governor. I accept what you say on the Fiat issue, but from
David, I can't hear you. Can you speak up, please? Sorry.
Can you hear me now? Can you hear me?
Yeah, just about. Yeah.
Right. I think the issue with the Fiat is the operation in the back cab more than the seatbelt. You know, there are problems because of the reduced amount of room in there, and especially the way the services are laid out. And also, if your patient arrests in the back of the ambulance, it is quite difficult to do a resus.
Okay, thanks for clarifying that. And I think the Chief Executive can address that in his answer. Yeah, Stuart?
I just wondered, have we asked London why they're exempt from Fiats and we're not?
Yeah. Ask the Chief Executive to also clarify that. I'm all for competition, but not for unfair treatment. Andrew?
In the spirit of your direction on questioning, Chairman, are the non-execs, have the non-execs been able to have a deep dive into the ambulance issue? Because I think I'm with Howard. It's probably not all about the seatbelts. It's as much about the layout of the back of the vehicle, from my experience, where it's extremely tight because of the way that CCAM, I think, have chosen to lay out the vehicle. So maybe there's an opportunity for a little bit more thought about how that's laid out to create a bit more space in what's clearly a
Thank you. Thank you, Andrew. You got on to mute there. Sorry.
Did you get the end of that, Chairman?
No, we didn't. No,
sorry. All I was saying was it would be perhaps useful to have a bit of a a deep dive into the back of the vehicle, almost literally, just to look at the way in which it's laid out to see whether more space can be created. Because my experience of attending as a community responder and in the back of that vehicle, and I'm slightly over 10 stone, so that's slightly worrying, but it's quite difficult to move around in the back of the vehicle once you've got the patient loaded and you're trying to take observations, and in my case, trying to help the crew with some of the things they were trying to do. So maybe that's something that could be just considered by the non-execs.
The majority, I was going to say, on behalf of my non-executive colleagues, this matter has been discussed. The majority of the item which is being raised at board level was relating to seatbelts. The other more detailed aspects have not been arisen, and these have almost arisen latterly. The major issue of debate, as far as I understand it, Philip can clarify it, has been the seatbelts. I mean, I think if the people have used the opportunity to use other items, which are should be part of routine quality assurance. But Philip, can you just deal with this in headline terms, please? And then...
Yeah, just that Stuart's also got his hand up. So shall we take that and then I'll go?
Stuart's final comments?
Yeah, we've had extra personal safety equipment given to us, i.e. the hoods, and we've got limited amount of space in the back of the Fiats anyway. Where we're meant to put the extra safety equipment, we've barely got enough room to put our own personal equipment where we're meant to put everything else.
Yeah, thanks, Stuart. I think, well, there's obviously chief executive can take operational matters away and how we deal with things, but in terms of this council's business, Philip, can you just address the issues of Fiat, please?
Yeah. So as Howard said, the Fiats are not were a nationally agreed specification to, and so it's the only one that people are allowed to buy apart from London. I'll deal with the London issue. I'm not entirely sure why they're still allowed to buy another vehicle, but it's something to do with the layout of their journeys and bulkheads, and it's an argument that is still it is still going through. So as far as I'm concerned, London will have to at some stage come in with the national procurement. That's the instruction that's been given, but at the moment there's that argument hasn't been won.
Philip, I wasn't aware of that. As an action, can we take an action, please, for you to draft me a letter, please, to my opposite number in London, so I can ask the question directly of the chair of the London Ambulance Service. Why is it then they're not able? Because when I look at TV programmes, I see van conversion ambulances in London, as well as the other. So I'd just like some clarification about what's different. So I would like to raise that as a non-executive, because I want to ensure we've all been treated fairly here. So I'd like to understand why, if that is the case.
The issue that we're dealing with specifically is the seatbelt. We've got Fiat, we've got a national safety advisor expert, and we've got all of our own internal team experts doing very shortly a way of making sure that you are safe in the Fiat. So it is the biggest selling vehicle in Europe. It does more miles than any other vehicle. We haven't changed it when we buy it and when we fit it out as an ambulance. We haven't changed the seatbelt at all. So Howard's point that this is legally and demonstrably safe is a good one. The West Midlands have driven over 100 million miles in Fiats and have no incidents reported. The same would be the same for East Midlands and the other totally Fiat trusts. So it is difficult when you change things. People don't like it, but I'm by no means saying that there are not some people who don't fit the Fiat. It's undoubtedly true that some people are doing it. So we have to find a way of working with them. Fiat won't be the choice forever unless they continually win in the national specific. The national team are at the moment putting together the spec for the next round of procurement. And there are other makers now that all the ambulance trusts are buying the same vehicle. There are other makers now coming into the market to provide an option. So that's one way in which we keep the quality good. On the back of the cab, I'm aware that some people say it's too small, and it is smaller than the Mercedes. So I know it's smaller than the Mercedes, but again, I go back to the point that all these other ambulance services have made it work safely for years, so either we've got our bit of the layout wrong, or it's a safe system because it's been proved to be safe over the years. But I will take the back of the cab issue back because we haven't spent a lot of time on that because it hasn't been.
Thank you, Philip. If I may, though, just to move on from the item, which clearly is important. Clearly, this is not the forum to debate the merit of fees regarding other ambulances. That's an operational matter which we don't do with the council. However, I do take an action whereby I certainly will want to clarify this London issue. I was unaware of that, and I would like that clarified, and I will write to my opposite number. I'll also ask my committee chairs, particularly the chairman of quality, just to ensure that in terms of the layout, I'm not aware of anything being reported where a patient has suffered harm as a result of having to be worked on in the back of a Fiat ambulance. However, if there are any instances of where people are genuinely suffering, there's been problems caused because of the layout, I think it's important we are notified about that in a normal way through the appropriate raising of concerns, but also through DATEX, but also it's something I'll ask the quality committee to particularly ask the question, are there any issues to do with the layout that's causing clinical concern? And because that's important if there are. I know it's a different layout, it's not as big as a Fiat as a Mercedes, but I'm certainly, when I've spoken to Cruz, whilst it's inconvenience, I've not heard of any patients coming to harm. We just need to ensure that's the case. That's that to be that. So, and similarly in terms of the other board committee actions on this, we will continue to. I will also take an action to raise with my colleague chairs around the country, around who I meet regularly, this issue. Nobody else has raised particular concerns about Fiat when I've been in the company, but I will simply ask the question, are there any other challenges that are being taken? Those have arisen. Okay, can we, anything else on the quality and patient safety? Sorry, on finance and investments? So, Martin?
Can I ask Howard, I mean, does the next financial year look like a perfect storm in the context of the different assumptions around inflation and how it's going to get worse, particularly with regard to fuel? The comments he made about non-recurrent SIP this year and the comments that Philip made about a potential another wave of COVID. And secondly, I guess, does the board have a view? Where are the commissioners coming from on this? Are they basically saying suck it and get on with it? Or are they basically sort of as part of the wider health service going back to government and saying this is unsustainable?
I think it is building up certainly to a storm, whether it's a perfect one or not. It's certainly a storm with those correct analysis of the challenges we face. I don't know if David Hammond's on the line or Philip want to comment, but I am acutely aware of those challenges and the responses that we're getting back from the ICS, the commissioners. So far, it's still early-ish, but so far have not been particularly encouraging in terms of yes, we'll sort it out. It's been a fairly neutral response. We understand where you're coming from. I think, just to be clear, I think our estimate, David, of the shortfall is going to be something, factoring all the sort of worst case into account, something like 30 million into next year. So, we are talking about a big issue, and certainly that's what we've been presenting to the commissioners as I say, I don't know if Philip or David want to comment further, but it is a major challenge for us.
Very quick comment. Yeah, the commissioners ICSs they're the same at the moment. They'll become distinct shortly, but they are in the same problem. So everybody is short, and they are all, of course, going back to the NHS, who are going back to government, saying that these numbers don't work, and that is usual at this stage of the thing. But it's as you say, Martin, it looks like a bigger scale than we have dealt with in the past.
And I think just to conclude on that, why as a board we will be obviously working with the executive, asking the executive to start to plan and look for contingency measures. It's clear we're going to have a challenging time from April onwards, and we have got to try and make the best plans we can to keep our patients, staff, and to keep our patients safe and for our staff welfare. And that's something which we'll be doing as a board for sure. But thank you for raising the point, Martin. Can we move on to finish off the board items with the Audit Committee? Then I propose to have a short break. Can we take the Audit Committee, please, Michael? Michael, I think Michael might have to just attend his other meeting, so we'll come back to that item if we may, in terms of the Audit Committee report. Can I suggest then we have a short break, and can we reconvene at midday, please? Then we'll crack on with the rest of the agenda. The Audit Committee report is read, so we're like colleagues please to note that. So we're going to move on then to item on Better by Design. This is to bring the council up to date with a preview, as it were, which is what an important change programme in the trust. So Philip, are you going to introduce this item? The Chief Executive returned to his laptop.
I'm ready to share the slides when Philip's back, but perhaps he's just.
Perhaps we
could flip it if Tom is content to do his
first.
Let's
go on to as Tom is here on time. So we'll go to the. Should we do the board committee scrutiny, the quality and patient safety committee deep dive? Tom, are you happy to?
Yes, very happy to. Shall we start with? I've got some slides that Kirsty is going to show.
Katie.
Can you put them in slides? Thank you. I see Philip's back, but we've changed it around.
You missed your slot there. We'll come back to you after quality.
Yeah. So thanks very much, everybody, for inviting me along to this to talk about QPS and to receive your questions. Thank you very much to Kirsty as well, who has supported me in the committee in recent months and has helped develop this presentation. Next slide, please. I sound like Chris Whitty. Next slide. Kirsty, can you move the slide on, please?
I'm not controlling it.
No, it's me. It was
okay.
It was going so well. I'm trying. Bear with.
I mean, there will be, I'd imagine, a slide deck in your pack, and I can talk to it if that's. Is that going to be the best?
If you keep going, Tom, and I'll just have a jiggle with this. For some reason, it's not reacting, but bear with. So if you just crack on.
Okay. So you have in your papers the existing terms of reference and purview of the committee. The membership, however, is updated, and we are in the process with Kirsty and Peter of updating the formal terms of reference paper. But the membership you'll see is myself, Subo, and Liz Sharp, and David, and obviously our executive colleagues, Rob, who's recently joined as Director of Quality and Nursing, and Fiona Moore, Emma as Director of Ops, and Philip as CEO attends with Peter. We have 6 meetings scheduled a year, and we do have some extraordinary meetings when there are issues that we really need to address. When there's either the trust is under particular pressure, or there is a particular pertinent issue that we need to get to grips with outside of main meetings. So all our meetings have been quorate. We've had very good attendance. And since I've taken on the committee, what we've started to do is review who comes, who's invited, because this obviously is a subcommittee of the board. So we have fewer people attending, although managers will be invited to attend for specific agenda items. We had an incredibly busy cycle of business that we soon realised was going to be unmanageable, and meetings became. The first meeting I did, I think I almost had to lie down afterwards because it was so full. And the problem with that, of course, is it doesn't give us the space and time to do our jobs of proper scrutiny and seeking assurance. So we have a process now, which now that Rob has joined us, of refreshing the cycle of business, and that will be happening in the next few weeks, alongside the review of terms of reference as I've just described. Next slide, please. So the current agenda is organised as on the slide. That the key innovation here, which is true across all the committees, of course, is the executive escalation. So that allows, and particularly the 2 clinical directors, to alert the committee to things that have come up at the executive management board, so that we can be aware of them and, if necessary, seek further assurance. What I've asked is, and with Rob and Fiona, is that going forward, is that they have a conversation with me prior to meetings, so I'm aware of what those escalations are and what we're trying to achieve. We have the standard management responses. So each meeting we will have, particularly where we've received partial assurance or we're not even there, is asking the executives to come back with more detail. So we receive that, and you'll see the examples of that. Around public access defibrillators, for example, clinical audit actions, and so on. And then we have our scrutiny items, looking at our systems and processes. And again, you'll see they're listed things such as serious incidents, themes and analysis, patient experience, which I know is something that council colleagues are particularly live on at the moment. And we receive the annual reports on those things that are listed here. And we also have then just a short bit at the end about, well, what's coming next, horizon scanning, what new clinical policies might be appearing, what's coming from NHS England or NICE or JR Calc, the Joint Royal Colleges Ambulance Committee, that might be relevant to us, or indeed local and regional pathway changes. Next slide, please. We have held 3 extraordinary meetings, and you'll see them listed here. Now, when we were under the cosh in the very difficult days earlier in the year, well, late last year, I should put it that way, it seems only yesterday, we agreed that we would bring the committee together just for assurance on how we're keeping people safe during the time when the trust and our health system was particularly stressed, and we were able to get that assurance. We had the issue of medicines governance and controlled drugs, and because of the issues that you will be aware of that resulted in 2 members of staff, former members of staff, being prosecuted subsequently, we held a joint meeting with the Audit Committee, and Michael chaired that with us. And we had another extraordinary meeting on this very sensitive issue of sexualised behaviours. And you'll be aware there's quite a bit of national work going on with ambulance services on that issue. Next slide, please. So in terms of outcomes and assurance from these issues, I'm not going to go through them all in detail, but the ones that perhaps I'll focus on are those where we have partial assurance, and we're going to need to keep a weather eye. So EOC and 111 clinical safety, EOC patient safety in relation to patients with mental health problems, infection prevention and control, and some of these, of course, we have discussed in depth at committee, but we've asked the executive to return to us with updates, and particularly things like, for example, the mental health issue. The changes were only brought in a few weeks before we had our item at the last QPS. So we're going to ask, once that's had those changes have had a chance to bed in, for more detailed progress reports. Next slide, please. So the scrutiny items are mapped to the Care Quality Commission's key lines of inquiry, and I'm sure we'll be talking about these a bit later today. And the monitoring, governance and annual reports are as listed there, and I won't go into those at this point. Next slide, please. So it's a pretty busy committee. I always reflect that healthcare and health and social care together are so complex. It's not about 3 different patient conditions. It's about anything that's out there, and how through this committee, quality and patient safety, we try to be assured that everything we're doing with patients is as safe as it possibly can be. Thank you.
Thank you indeed, Tom. Very, very detailed exposition of the work of the committee. So, colleagues, questions of Tom, and I think particularly would like your assurance that the subject matter being discussed, as it were, the range of topics which quality committee have got in their eye line. It would be good to get the council's sort of feedback. Are you content that we've got our eye on that? They've got their eye on the main items, or other things there that possibly we ought to be paying more attention to, in your experience, in terms of quality and patient safety. But in terms of the actual work of the committee, I will now take questions. So I think Nick, you were first with your hands up. Hi, Nick Harrison.
Hi, Professor Gwynn. How are you? Hope you're well. Yeah, my question is about the we were talking about hear and treat earlier, and alongside this there is an increase in clinical decisions being made to treat people over the telephone or refer them to other people. So I just want to know if there's any kind of clinical governance for that decision making, if there's any governance over the decisions that have been made, and because this is being pushed and increased more and more, is there any relationship between those decisions and sort of SIs or complaints that have been made? So as a whole thing, really. I'm just wondering if the committee is also looking into that aspect, with it being on the increase.
Thanks, Nick. A very important question. And yes, through thematic reviews, through our regular reports on serious incidents and indeed complaints, we do get a sense for whether anything concerning is appearing. I can't say that that there are any trends that suggest hear and treat is not safe. In fact, we've been having a discussion. We had a board away day last week about what is the sweet spot, if you like, in terms of what proportion of an ambulance service's response to patients should be hear and treat. What's the right number? And we don't know, but what we do know is that some ambulance services in this country do have higher levels of hear and treat and are not reporting safety concerns. But the key thing about safety, of course, is monitoring. So that's in place, and the clinical supervision, if I can call it that, but the clinicians in EOC 111 who provide that oversight and are able to be there when someone who perhaps isn't as experienced or qualified can seek advice. Those sort of safeguards are in place. And of course, for the 111 side, that's heavily monitored and audited as part of the contract. But we do have oversight of that. We have had several very, very detailed presentations to QPS on all these processes. And of course, what you can have, when I talk about clinicians, of course, you know, our PPs, paramedic practitioners, and that extra level of senior expertise is available to support decision making. A lot of this is algorithm based through pathways and a new system that I can't remember the name of, that someone may remind me of. PACS, yes, that's it, yes. Which again is subject to, as part of the national system, heavily governed to ensure safety, and where amendments need to be made, those are happening promptly, and the impact of those changes is being watched very closely. So I think we spent a lot of time looking at these sort of things in committee, but of course in through the management structures and oversight, there's a lot of work going on to keep people safe.
Yeah, thank you. I think the key thing is it's about, I've been in that position myself, and it's a lot of it is about experience related to risk management with the patients, and that oversight of the senior people within the room. The staffing has to be there to give those people support. That's just something, a general observation that I've always found when I've been in there working.
Yes, thank you. And Philip, I don't know if we had a bit of investment. It's probably fixed term investment, isn't it? But to bolster the support available in EOC 111.
In EOC, we've had investment and separate investment into 111. Right. So numbers of clinicians has gone up, although I would be not accurate if I didn't say that there is a shortage of clinicians. They're very difficult to get hold of, but we have got money to increase the numbers. It's non-recurrent money at the moment.
Yeah, that's the term I was looking for. But yeah, thanks.
Thank you.
Thank you. Stuart?
Yeah, I just want to, hospitals are having problems with handover times, and we're seeing significant handover delays. What are we trying different with system partners to solve this problem? Is there anything we can do to help the chain?
Thanks, Stuart. A really important question there. And obviously, this is a very live issue across the country, to the extent that NHS England have instructed secondary care, so hospitals, to not have any handover delays. Now, that's easy to say. It's much harder to fix, because, of course, exit block from the emergency department onto wards. When people are having when hospitals are having difficulty discharging patients into the community for various reasons, support packages or appropriate accommodation, this is a whole system problem. What I do know, and actually this came up in the escalation reports in the integrated performance report at the last board, about the amount of effort the executive are putting into engaging with the wider system partners to try and fix this. And when we think a few months back, when there were parts of our region that were particularly having problems with handover delays, the initiative to try and help fix this, because I think it is try and help fix it. We can't fix it all as an ambulance trust, came from the executives in our trust. So that was good. And so much of this is about relationships. You know, and I am assured that the relationships are good, and I better say also that the chairman also talks to his fellow colleagues on this. The other thing is that more sort of, and in December we had a report to the board, and again a bit more about some of the fixed term monies that Philip was talking about, is to fund HALOs, so hospital ambulance liaison officers, in some of our more challenged acute partners. So you'd have a sort of in fact, Fiona Moore has been out there doing some of it as well. I know she's been telling me about it. Having someone with a degree of seniority who can work between the crews who are queuing with patients and make sure they're safe and being looked after, and trying to this is a very technical term, chivvy things along in the hospital and see whether patients who need priority are given priority and so forth. So there's that sort of on the ground support with a little bit of extra funding that's come in for a short period of time, and there's that sort of more strategic working at the system level, which is proceeding. And I know from the Southeast regional meetings of NHS England with all the directors and all the bosses, if you like, and the chairman kindly shares the slides from those meetings with NEDs occasionally, and we can see, what that pattern looks like across the region. It is uneven. We have some parts of our patch that are more challenged than others, and we just have to keep working at it with them.
I think Stu, you raised an important point there, and Tom's obviously given a very detailed answer. But we do make representations to the trusts, and quite frankly, the point I keep making is that unless we crack this one in terms of the flow of patients, the hospitals will not have a chance of being able to reduce surgical waiting lists, because the patients that are in that queue usually end up in medical beds in the hospital, which overflow into surgical beds. The whole system blocks up, as well as the difficulty being moved on. Yeah. So we are making representations, and in fairness to the integrated care systems, as they're developing, they do get it. I mean, there's just the time lapse is going to be significant, Stuart, in terms of this is a system issue wider than the National Health Service. This is an issue that goes into social care and others, and this is just a symptom. The queue is a symptom of that, I'm afraid, of wider issues which will be addressed, but it's not going to be addressed quickly. As far as I was going to say, there's some big challenges ahead. That's why I'm really encouraged by initiatives such as our Community Falls teams and others, because the challenge we have and which we're trying to get across is the less patients we convey and the more we can deal with through Hear and Treat, etc., reduces the demand on emergency departments and keeps the slots for those really seriously ill patients who need to be there. So that's the way it's going on. So it's a multi-layered representation from the trust, essentially.
Thank you, David. And you just made the point I was going to make about Hear and Treat and reducing conveyance rates, doing it safely, of course, as we've described earlier. Thank you.
Yeah, absolutely. Thank you, Stuart. Any more final questions for Tom regarding the deep dive into the Quality and Patient Safety Committee? I hope you could take assurance from the fact that the committee has a very detailed agenda and is very focused on key items of patient safety. I hope you concur with the subject matter, as it were, but encourage it, particularly through our staff governors, through the appropriate process. If there are issues regarding patient safety, we do have systems there for concerns to be raised, and I keep making the point, if we want to know about it, eventually it will get through to the Quality Committee. If there's any trends emerging that we do need to look at from board level. So it's really important it's from top to bottom of the organisation. It's linked. Okay, let's move on then to the go back to the Better by Design item. Now, Philip, you're going to give the council a sort of initial preview of what's going to become a wider issue with the trust. So this is early days yet in the programme, so this is the first step, as it were. So Philip.
Thank you. Who's driving it? Is that Katie?
Yep.
Yep, thanks. So a couple of things to start off with. Firstly, I haven't shared these in the papers, and the reason for that is that I'm giving this to this committee, to COG, earlier than I should be. It should be going to managers and staff, and then to others. So you haven't got the entire thing. We haven't got time to do the entire thing, but I will give you a good picture so that you'll at least understand where it's from. Secondly, Better by Design itself is a label for the way in which we are going to achieve our strategic delivery plan. So all of the things that are being done under the Better by Design umbrella come directly from the strategy in the strategic delivery plan, and Better by Design is the vehicle by which we're going to deliver them. It's really, really exciting, and it's going to be the biggest thing that I do in my tenure as chief exec, I think. And I think it's probably the work of years rather than months, but I'll give you an idea of some of the timings. So the overall programme, you can see the various bits of jigsaw. I'll talk you through through them in a second, but there are 6 programmes that are tied together by a Better by Design portfolio, so that they all deliver at the right time for each other. The most important one of all of them is that care delivery model that Tom was talking about earlier. So the care delivery model, and I'll give you a bit more detail in a second, is the thing that says this is how we are going to run our business to keep patients safe and to give our staff the best experience we can possibly do. So that's what the care delivery model does. Everything else in those other projects are there to support the frontline care delivery model. So the care delivery model comes not essentially first, it actually comes second, because we need to, in order to inform it, we've got to do some pre-work. Then we will decide on what that care delivery model is going to be. And as David said earlier, it's a question of taking a really fresh look and saying, how do you do this better? And I'll give you the breadth of it later. Then there's the clinical education strategy and pipeline. So that is there to supply the care delivery model. So rather than we do all our training in the way that the trainers want it to be done, the care delivery model says this is when we need staff on the front line, and the rest of the organisation has to do the recruiting, the training, the equipping, and then hand over, to use one of Boris Johnson's favourite phrases, an oven-ready member of staff at the time that ops want them and need them to deliver patient care. Then there's the staff development, training and OD. This is about giving us all the skills and the experience and the development that we need to, one, to grow into leaders, and secondly, to look after each other well. And I'll say the organisational redesign, that is just, as soon as we know what the care delivery model is, we're obviously going to have to adjust some bits of the workforce and some bits of the corporate services. So that's the organisational redesign is to do that. And then the external relationships, that's all about getting the trade, the money, the activity that will pay for all of this, but also adjusting the way that the other systems are set up so that the care delivery model can work. And the one that I probably should have started with is the performance cell and predictive planning. This one we've been working at for some time now, and that's the reason why we have a director of planning, someone who really gets how do you, with some degree of accuracy, decide exactly how many people you need, when you need them, and how to get the best out of them, and then say, okay, if these things happen, this is what will happen to your performance, this is what will happen to your care. And so it's having a thing that's the really exciting precursor to the care delivery model. So next slide, please. So you can see that those 6 programs down the left-hand side of that chart, and then across the piece there's indicative or the timelines. As you can see, this doesn't stop this year. Still going to be running as we get into next year, but lots of it will, the bits of it are implemented already. Bits of it will be much later, and we have to do them all in the right order, otherwise it doesn't work. And then if you go, given time, we'll skip the next slide and go straight on to the one after that. Thank you. So the progress that we've made. So far we've got as far as designing the programs, and we've decided who's going to run each one. We've given them the starting points, the deliverables that they're going to do. But what we haven't done is decided on the big bits. So this is not a centrally top-down decision-making process. This is going to be for the engagement that starts shortly, to decide on that really important bit. What is the care delivery model going to be? And I think that I can move on to the next slide. We'll start looking at the performance cell transformation. As I said, this is the first one in in timelines. The three key work streams are: can we decide how many people that we need to do the job a certain way? Then can we predict and understand what will happen to performance as we change those things? And thirdly, can we provide enough evidence to the centre and to the commissioners and others that our figures are completely bomb-proof, so that we have a much better knowledge and we're way ahead of them, so we are more likely to win the arguments over, if you want a product, this is what it will actually cost you, and this is how we best deliver it. Next slide. There are three bits. Firstly, we are bringing in a modelling tool called Optima. That's to allow us to, in the past, when we've said, okay, let's put an ambulance station or a standby point there, we sort of guessed whether that was the right place. These modelling tools, you can run last year's data, and then you can move a station, and it'll tell you what the impact would be on performance. And so your decision making suddenly becomes scientific as opposed to just best judgment. That's well underway. It's being brought in, and we've got people working on it at the moment. It takes time to set it up, so you won't see the benefit of it until quarter three, quarter four. The second one is a planning tool called Anaplan. What that does all the ties together all of the various different bits of how do you secure a workforce and deploy it, and at the same time pay for it. So every time you make a change to a deployment rota, for example, that changes the cost automatically. So it's a combined planning tool. That's part of our evidence, and that those two things there will make us such a much more informed and intelligent customer, but also better able to run our organisation. And then down at the bottom, you can see in the purple box, I think, it's the quarter two. That's when we're going to decide on the care delivery model. So performance cell, really exciting. If you ever get a chance to talk to David Ruiz Salada, well worth it. He talks a fantastic story, and it's really important. It is the most important thing that we've done for a little while. So moving on. So care delivery model run by Emma Williams, who's the ops director. So it's the ops director designing and the ops team designing the care delivery model for themselves. This diagram, just the reason I put this up is that it shows all the inputs into the care delivery model, but it makes you'll hear people talking about virtual. Sorry, my glasses aren't working. virtual and physical responses. That's the new language that we're going to be using because it's going to be much more than hear and treat. The use of sight over what someone my age probably calls a video link is going to be increasingly common in control centres, and that's going to allow us to make some of those big differences. Where at the moment we can't risk doing a hear and treat because we haven't got the knowledge. With some help and some more of the clinicians that Tom was talking about, that's where we drive that. The reason that we need to take things out of the physical and put them into the virtual is because every time you send an ambulance, that burns diesel, burns time, and everything else, and uses a huge amount more. So the rough transition is that it's about 7 to 1. Every time you do one more job, every time you add someone in who's going to do this role in a central location, you save the requirement for 7 people out on the road. So that's the benefit of it, and that's what we're trying to do. But how we do it is going to be decided by the experts and the people who do these roles. Next slide, please. And you can see on this slide that Emma's starting point is that she's starting at about 10% of hear and treat, and she's trying to get to 15 to 25, somewhere in that range. And is that deliverable? Well, a couple of trusts are already delivering it, so it must be deliverable in some way, but we need to do it absolutely safely. And if we do that, then the pressure comes off all our road crews, and that means that we can get their rotas working, we can get them finishing on time, we can get them to patients on time. So it takes out all the heat out of the overheating engine that we've currently got. So that's the better by design care delivery model, which is the most important bit. Everything else that I'm about to talk about, and I'll talk really quickly now, is simply there to deliver that care delivery model. So the next program, sorry, the objectives I won't go through. We haven't got time. So clinical education have got to deliver, as I say, a whole bunch of stuff there that supports that care delivery model. So they can't deliver it until they understand the care delivery model in exactly the way we want to do it. But what we've done so far is we're setting them up with a strategy that will enable them to be able to adjust to the care delivery model as it's decided. Next slide. In terms of education in the wider sense, and training and development, that's this program. It's the standalone program, and it'll be done again with consultation and engagement rather than instruction to the users, i.e. Emma and the ops folk, because that's who needs to benefit from all of this. I think I'm going to say nothing more about that. And next one. Organisational redesign. As I said, this is simply about, I say simply, it's never simple, but it's the way in which we make sure that the organisation is right-sized once we've decided on the care delivery model. So we will have to have some form of restructure. But what that restructure is, we won't know until the care delivery model is designed. So let's move on to the last one. And that's the external contracting and external things. This is run by the Chief Operating Officer, and he and his team have got the job of, one, influencing how the rest of our care systems are designed to support our care delivery model. Secondly, to win business and influence business and make sure that the money that comes to us is able to afford the care delivery model, and to then make sure that grow our reputation and our influence, so that we become the partner of choice in all things urgent and emergency care, and everything pre-hospital anyway. And that when I talk about that, I'm not only talking about 999, I'm talking about 111 as well. So I think we'll move on. So I think you can stop sharing. Thank you very much. So it is a really, it's a huge program of works, a portfolio of programs, and it's really important, as I said at the beginning, that they're delivered in the right order, because as I've stressed all the way through that, if the care delivery model was, as soon as we got a good picture of what the care delivery model's got to do, then all the other programs need to swing in behind it to deliver everything at the right time, at the right pace, for the ops team to actually deliver that care delivery model. It's very exciting, and I commend it to everybody, and you'll be hearing lots more about it soon.
Yeah, thank you, Philip. I'd just say that is there just for an introduction to the council, as it were, and it's still, we are very still in the early stages of formulating the programme, with the aim of improving our service to patients within the resources we have available, and to give our staff a more fulfilling work experience. We're currently, I think Philip's point is so well made in terms of predicting our work. We're an organisation that runs on adrenaline. We are very good at doing things at the drop of a hat and responding, but actually what we've got to get better at in CCAM is actually beginning to predict what's becoming an increasingly uncertain world. But have we got the tools and techniques to predict our workload and plan accordingly? And that's really so important, because we do react extremely well, but we can plan better and anticipate more. And that really is the essence of what we're trying to, why the board has sponsored this programme. So the discussion is not getting into the detail, it's about making sure that any initial observations for which we as a board, and particularly the non-executives, can take on board, in order to ensure that we support and challenge the executives as appropriate as we take this programme forward. So colleagues, any initial reactions or questions that the board need to take note of? Nick.
I'm back online.
Yeah, Nick, come in.
Thank you for that. Really interesting. My only query would be that a few years ago within the trust, I think we might have even been Kent. Well, I worked for Kent at the time. We had a similar sort of shake-up, and they introduced a system called System Status Management by Mr. Stott over in America, which was very, very theoretical and works in some parts of America and is applauded. In other areas it falls apart because it's not aimed at a mixed demographic. And it was very theoretical in style, and also found that the data that was being used very quickly got out of date, so the whole system kind of went out of kilter, and it didn't function very well. This sounds like it's got a lot more planning behind it, and I think the implementation and the understanding of how it works is vital. It's really good to see that the education element is playing a key role in all of this. I think the one thing that worries me is, like with most operational people, is that unfortunately education and training are always victims of operational demand. So it's great when it looks on paper and it's theoretical and we're going to do this and then we'll have that, but as soon as the demand changes, that's the first thing that's sacrificed. And I think it's always seen as a luxury rather than a necessity. Hopefully with this, it will be seen as an integral part and a constituent part of how we function and how we move forward. So that would be my only kind of worry about the system, is that previous system, which is similar in some ways, that was theoretical and based on historical data, was very, very it didn't work for us. It works in America in some very simple, in I think Charlotte, North Carolina, it's because it's a very formulaic system. You know, every square mile you have an ambulance station, every second square mile you have an urgent care centre. So in that, but I'm really pleased that the emphasis is changing. I think along with that, if you're going to have more hear and treat, like I mentioned earlier, the standard of training and education and experience to some degree of those staff is paramount to the success.
Yeah. Nick, I'm pleased to say that was exactly the conversation the board had about how do we protect the training element, because without doing something about that, and that's what the deheating, this overheating engine allows you to do, and just it doesn't work without it. But and your system status plan, I get it. We still used that in my last trust, but we used it alongside a modelling tool, so you could continually remodel whether you had things in the right place, and that's what made it work.
I think it has to be dynamic, and that was where the failing was when it was implemented here. It seemed very rigid in its structure, and I think because you don't know what's next after COVID, you have to be fluid now, and we have to be able to change very quickly. So hopefully
the key point which the board have made and our executives have made as well is that what we're keen to see is engagements. This is not something that's going to be manufactured in the boardroom, and we've really sort of challenged the executive colleagues on this. This is something which can only be designed with engagement of those that are doing the day job, and that's something that's going to be really important that we stress that. And that's why, you know, it's glad you've responded the way you have as a staff governor. That's our message back to staff from the board, is that this is better by design with the staff, not against the staff. And that's really important. We have that message across. So then Martin, then Kirsty, then Andrew.
I've got the battle scars of what happened between 2006 and 2012 in the run up to the Olympics, because I was heavily involved in doing this stuff in that context. And I mean, I suppose the one thing that from a governance point of view that would concern me would be organisational overreach, trying to do too much simultaneously. What we found was that the biggest bottleneck of all was the executive's time, in the sense that you go along to programme or project boards, the key director couldn't make it for all sorts of pressured reasons. Decisions couldn't get made because we had to refer it to X or Y. So I think a critical success factor here will be the extent to which directors prioritise their role in this vis-a-vis everything else. And that's the most crucial thing. The other thing is that as the person who was responsible for doing the performance management reporting to the executive team and the trust board in London, you mentioned two tools, and I mean, maybe this falls within their scope, but the difference between having a slick electronic form of performance reporting as opposed to a manual one is enormous. When I first started at the LAS, I used to spend 1 week out of 4 just going around trying to pin people down to find out what the hell was going on so I could report it. So for me, I would say those, in terms of critical success factors, from my own personal experience, are probably the primary ones, just to bear in mind, if I may say so, without wishing to be presumptuous.
Yeah, thank you, Martin. No, I think the board will take that on board. Very good advice. Thank you. Particularly the organisational overload or executive overload, we're very mindful of. So thank you. Thank you. Kirsty?
Mine was probably, it's just a challenge for something that Philip's just said. I think it's when the executive and the trust board go out and start to talk to our staff, we need to be really mindful of the language, because something that Philip, you just said, was the only people that count are the people on the front line. You didn't say it in that, you didn't say that exactly, but I'm paraphrasing. When you go back to the minutes, you need to think about how we demonstrate this and how we present this to the trust. You've got just short of 500 corporate staff that support absolutely everything that the frontline do, but actually they were a second thought in that presentation. Then you've alluded to it in the training that it's for everybody, and it is for everybody. And actually, do you know what, I commend the fact that that is actually come in, because it's been stalled for so long, training right across the board. Our organisational development hasn't happened in excess of 3 years. So actually we need to do that. But can I just make sure that when we're doing this out to the rest of the staff, when this is being presented, that we actually look at the language we're using, because That was the first thing out of all of that presentation. The only thing I've remembered is what you said, Philip.
Okay, thank you. I will take that. But we are all here to support the front line, and I know you've just said that, and that's what I was saying. That you know, if the rest of us are doing things that don't affect that, then you know we should be looking at why we're doing them.
Yeah, but thank you, Kirsty, for
point's right.
We take that on board. Certainly the board perspective on this is to ensure that we're all here in the sense particularly the headquarters services, corporate services, to make sure that when our clinical staff are engaging with patients in EOC or on the road, they feel absolutely supported and there's nothing getting in their way to give the best possible patient care. Yeah. And that's what we've got to ensure the organisation is completely focused on. It's not about us looking up to the boardroom, it's about the boardroom looking down to the front line and making sure we get that across. And that's the essence of this, but language is important. And I think you made a really good point there, Kirsty, and we'll make sure that's taken on board. Thank you. Thank you. Andrew?
Thank you very much, Philip. Very interesting, and every best wish for what is clearly a massive change management programme, which I've been involved in most of my career. So good luck. It's a challenge, I know. My question was really one about the change that was made some years ago when we had a balance of SRVs to DCAs that was different from what we now have. And I think that was changed by the ambulance response programme. I think that was a requirement in terms of attendance of a patient carrying vehicle on C2s, etc. My question is, if we're to manage a different care model and plan over a period of time, will we be able to also influence the ARP programme to enable the shift of the requirements of the ARP to be managed to whatever the care model is that you and Emma Williams come up with?
Mm. Yeah, I think, Andrew, the bold presumption that we're making is that ARP ain't going to change again for the next 5 years, and therefore we will have to make the care model fit ARP as opposed to the other way around. There's so much research that went into it.
So the restrictions that are there in terms of what you actually send to a patient will be largely around ARP as it is now. Is that right?
It will need to work right with ARP. Yeah. And there's no restrictions. You can have whatever vehicle mix you like.
But it's that patient carrying bit on C2s, isn't it? Which is
you're right that
limiting.
It was an essential thing, and the modelling tool will tell us what the best mix is, and make sure we keep it up to date.
Thank you very much, and good luck.
Yeah, and to know, thank you, Andrew. But to note the point you made, I think I'll ask through the board subcommittee, particularly the governance of Better by Design. What we've got to ensure is that yes, we've got to work within a national framework, but that national framework has got to inform local decision making. And what this programme is about making the best decision we can for local people in the southeast of England. So we will make sure that balance is struck there between, and in terms of the governance, we'll pick up the points you make, because and we have to go back to the centre, we will. But I think, like Philip said, I suspect we're going to be largely governed by for some time, but we'll put some safeguards in place for sure. Thank you. Can I conclude on that item, because we've got to go, because I'm equally excited about the community falls thing we're about to hear about, which is important about the future. We need to talk about the present as well. So can I just say, Philip, thank you for that presentation. I think the council are aware. Can I just say that at this stage, though, is still to be more widely rolled out, although we're doing this in a public meeting, and obviously staff governors are hearing it as well. So I'm asking you, Philip, in particular, to note the comments made by our staff governors in particular regarding how we roll this out and how we present it. And clearly we need to refine our presentation as time goes on. I know some of our communications team are online as well. I'm sure they will help also in terms of crafting the message. Thank you for that.
Thank you. Great feedback, guys. And for those of you who do end up talking to the CQC, it wouldn't be unhelpful if there was the odd mention of a strategic plan.
Not that we wish to coach the witnesses, but that's important. It's important that that information is certainly shared. colleagues, let's move on to something which is a very important item. I mean, and I'm sorry we're late getting to it, but we've got the community falls team. I think Andy Cullen hopefully is online, consultant paramedic, who is going to make the initial comments onto this very important item.
Thank you, David. Thank you to the council.
Hi, Andy.
Invited me along. Thank you. I've got a few slides. I can't share on this login.
Just going to do it now, Andy, for you.
Yes, Katie will there to assist.
Thank you. And while they're going up, I apologise. I think I've used the wrong template. So if the slide deck is not accessible to everyone, I apologise, and I'll change the template and recirculate as needed. So just waiting for the screen to update. Fantastic, right. So yeah, just the purpose of this, I just wanted to give an opportunity to update the Council of Governors with the project as is, to look at how much progress we've made, and also to look back and be realistic about some of the issues we've dealt with and how we've overcome them, and importantly to ask you what your views are and to provide any challenge for us. There's a lot of passion behind this project, and hopefully that will come out through the presentation and through the work that's been done by the project group. I have a lot of passion about fallers. My personal story with falls, which has driven my involvement in the project, was investigating a serious incident several years ago now, regarding a patient that fell and who was uninjured at the time of the fall, but spent 3.5–4 hours nearly against a hard surface, and acquired disease processes that they wouldn't otherwise have acquired. So the fall itself was not injurious, but the long lie led to a significant increase in their morbidity. One of the disease processes was life-limiting, potentially life-threatening. They recovered from that, fortunately, but they deconditioned and became more dependent, and their quality of life was affected. And it does have an operational impact as well on our colleagues and staff. Attending a long lie as a caregiver can be very, very challenging, and risks moral injury, so fronting essentially a failure in a system. So there's a wide range of issues associated with this. So I'm glad to be able to update you today. If we can go to the next slide, please. So just a very brief feedback of where we are in terms of a post-launch. So we have actually now gone live, which is really exciting. And that was on the 22nd of February. So we did a 24-hour look back and a 1-week look back, and we've had no staff or patient safety issues, which is really, really encouraging. We're seeking feedback from the CFRs through an audit form. So we're having some early difficulties with getting consistency, and that may be access to IT infrastructure or times of day. And we're also working towards going to the BI team to get more reporting. So the EOC leadership team have put a lot of work into making sure we can identify our falls responders assigned to CAD incidents, which is also really helpful. And more recently, we're getting more and more interest at a system and place level, particularly around inpatient flow and care close to home, particularly in the care home sector, and that links to our quality account aspirations, some of which have been rolled forward for a further year. And we're having some really interesting conversations with other sectors beyond care homes and the like. So we're currently doing a small sub-project with Mole Valley, who are the Careline provider in parts of Surrey, who have mobile agents who have looked to our training and our model as a way of mitigating their reliance upon the ambulance service for patients or clients of theirs who have pulled their Careline for a non-injurious fall in the home. So there's lots we can do. This is more about making falls a social problem and less about an ambulance service problem. And although small steps, we are making really good progress. The future clearly will need to be more CFRs, re-engaging our fire and rescue colleagues, which has, for various reasons, had to take a slight sidestep. And looking at further external partners. Next slide, please, Katie. Just in the interest of time, I won't talk to this slide too much, but I just wanted to which just demonstrate how we've managed this project, how we've got it off the ground through the model of care agreement and controlling the project very much within that project management environment. So Naomi, the project manager within medical, has overseen this project and has driven it with gusto and passion. So we're very grateful to her and everyone in the team that's led to our first early deployment, which too soon to be reporting back, but we know in fact there is a strong supporter of the project on the Council of Governors, who I'm sure will who's himself attended some calls already. So but we'll have more reporting shortly. And in terms of internal governance and safety, if we can go to the next slide, you'll just see an example of the highlight report model that we use within the medical directorate that we escalate through to make sure we've got oversight through to Fiona Moore, who is our SRO for this project. And of course, she updates executive colleagues on the progress of the project, and you'll see there's still some risks, there's still some issues that we're working through, but having that in that project controlled environment is really helping us. And the big milestone for us is that first deployment of our CFR teams in Gatwick and East Sussex, who've had the training and the clinical modules to help them attend to those patients. And then the last slide, just really a summary, hopefully to reassure the Council of Governors that we are progressing well. We've had some challenges, both in terms of COVID, with organisational focus and prioritisation of performance, having to look at the capacity within the community resilience team. But we've been fortunate that we've had the project support, and we've been able to run the project within that governed framework and strong support from executive colleagues, obviously particularly Fiona Moore and Emma as the Director of Operations. So I hope that provides a rapid but reasonably comprehensive overview of the project to date. And I'd be very happy to take any questions, suggestions, ideas, challenges.
Thank you, Andy. Before I bring in Andrew for some perhaps a bit of a local flavour, as it were, into this project as well. Just into the headline terms, if I'm an elderly person living in East Sussex and I fall over in my home, what's going to be different for me as a result of this service?
So the challenge for fallers is they never triage high up the system. And Philip talked about ARP, and that is a reality.
Yeah.
So when we looked at the problem, we tried to find a solution that would work alongside ARP. So what's different is we don't artificially elevate the call to be a C2 or a C1 and sort of cook the books. We've decoupled the journey, and we've broken it down into the bit that you need a quick response for and the bit that you can slow down. So the difference is, if we have availability and they're booked on, we send a community falls team as quickly as possible, and that's coordinated through the EOC clinicians, and they will come along and do a range of things. First of all, it's just good human care, just getting a friendly face down to their level, start talking, reassurance, warmth, and then they move into what we're calling comfort measures, which is addressing the risks. So making sure that they're hydrated, they're warm, we can ease their pressure areas, which is quite a significant thing to do for someone who might be laid on a cold, hard surface. Then working with our urgent care hub, so speaking to a PP, making a plan to see whether it's suitable to use the lifting aids to get them off the floor. So we're using the riser chair currently, which is working really well. We obviously have a very low threshold for escalation to get someone in green to come along. But if all is well, we can get them off the floor, comfortable, address those long lie risks, and then it stays as a C3. We haven't stopped the clock at this point, as per the ARP rules. The job stays on the CAD, and we send a green response, as we've tended to sort of call it in the project group, who'll come along and do the medical causation, so to rule out any sinister reasons why the fall occurred. And of course, if the patient has got an obvious injury, a head injury or a fracture, then that primary responder can provide really good intelligence to get a timely response for an ambulance. So it really helps our EOC staff to prioritise that large C3 pool. So yeah, hopefully it will feel quite different, and it addresses the anxieties of the CFRs, quite understandably, and fire and rescue who are interested partners, which is being stuck on scene for a long time. C3. So we've got this interrupted model of care where the responder can stand down after they've resolved that long lie risk and before the secondary response or the green response comes. So it looks really quite different, and it's been a leap of faith for the organisation, but it's been well governed and well considered.
Yeah, well done, Andy. It's really nice explanation. And it really is what's coming across to me is a really patient-centered approach, and that's just so important. So thank you. I mean, Andrew, before we go to further questions, you've been a passionate advocate of this service, and without breaching any clinical governance guidelines. But from what you've seen in the first week, are we making a difference?
Well, I think so, Chairman. I think we've been able to, in the Gatwick area, attend a number of fallers. They've all been quite different, and I think probably not exactly to the model we'd anticipated. But when we look at across the trust at some 6, 7, 8, 9 hours to get to a C3 call, then any difference we make to one patient has got to be a great move forward. I think community responders are very enthusiastic about being able to help this group. And I think, as Andy's rightly said, the model of care which allows interruption to that care is the critical success factor here to get CFRs to volunteer, to go partake of the training and then be able to respond appropriately. We've got the kit to be able to do so. And I think that, the success will follow. I think the important part for us as a trust now is to, once the period of monitoring has gone on, just to make sure that the system is robust, is then how we roll that out across the trust, and how we roll it out in those 2 OUs, especially to enable more CFRs to attend, because at the moment we've got a very restricted group in both locations, but I think we'll be able to roll that on. And in fact, on the 10th, I think it is, Andy, we've got another project group meeting to review how we put forward suggestions for phase 2 of the project, which will include the expansion of the scheme. So I think from the council's point of view, I think it's a very important initiative. I think it shows how the integrated model of care between green people and red people, i.e. CFRs, can work effectively for the trust, and how we can better utilise our volunteer colleagues who can really make a difference. So it's a very exciting time. But it's been long in the gestation. It's been long in the gestation and taken a long time, Chairman, as you know, because I've bent your ear about it a few times.
It's probably take a while to get it right, and I think also the other point is the cooperation with other emergency services, particularly the fire brigade, fire and rescue. I think that's also going to be very important for the future in terms of us doing the right thing for patients. There's 2 questions coming in. Matt Morris, then Nick Harrison.
Yeah, so I apologise if this was covered, Andy, in your presentation. My signal's been dropping in and out, and I've just tried to pick up everything I can from what you covered. But my question was very much around the governance of the programme and how we're sharing the benefits in the wider context. So is this something that's going to the Association of Chief Execs, or is it going to the ARP programme, or is it going, in essence, if this is successful and actually really does show the benefits we think it can see? And I mean, I'm one of those people that unfortunately has heard about this on the ground, because I might also have a red jacket lying around somewhere. But if it really does provide the benefits and the patient quality aspects that we believe that this has the potential for, I suppose my question is, what's the governance stream upstream from CCAM to ensure the benefits of this are shared with the wider ambulance service network across the UK?
Absolutely. Yeah. So using volunteers to respond to fallers is not new necessarily within the ambulance sector. So we'll be feeding into that wider knowledge base. I think of as much interest is the emergence of the ICS ICB, and how we start to show that benefit at system and place level, and how we share that data effectively, because we know that from our data, once you get past about 2 or 3 hours of being on the floor, conveyance increases 10% per hour after that. So, and that will link to inpatient spells. That'll link to some of the priorities around hydration, deconditioning, rehab potential. So there is a big impact of our actions at a system level. So I'm as much keen on sharing with the system, and getting them to reciprocally support things like helping us with care homes. So care homes are a big issue in regards to their approach to no lifting policies, and but offering them the same training as we're offering to the Careline provider in Surrey, as I mentioned earlier, and sharing some of the success that way, and looking at the trends, looking at the sort of it's very hard to prove something that didn't happen anyway, and that's the problem with doing these sort of preventative type things. We know but over time we will hopefully see a reduction in, just from our data, quantitatively less long lives, and then reporting at a system level less inpatient activity.
That's great answer, that Andy. And we affect as a action, I think, for board level, particularly the Quality Patient Safety Committee, which asks is that how do we learn lessons from this? How do we promulgate this? How do we govern it appropriately and change practice across the region? So I think some well-made points there. We need to keep moving because we're way behind time, but this is important. Nick Harrison next.
Yeah, hi Andy.
Hi Nick.
Hope you're well. Yeah, just want to reiterate basically what everyone said, and I've been banging on about this for quite a while, and I'm interested from a sort of clinical perspective, the danger and damages that long lie, as everyone calls it now, do to patients. And I think this shouldn't just be seen as getting there and picking up the patient. I think it's also preventing. It's a preventative measure. If you can recognise and get to one of these patients who's been on the floor for only an hour or so, rather than 6 or 8 hours, whatever, then you are reducing that risk, not only of a conveyance, but the ongoing costs of someone who gets an acute kidney injury or pressure sores, or and also the rehab aspect. My mum fell over and she was on the floor 16 hours, not in our trust. Luckily, she had not so much clinically wrong with her. She did have a week in hospital, but it was the long-term effect. She's now definitely more frail. She's worried about falling over. So those impacts are there as well. So if you can preempt that by getting people there, absolutely, totally agree. It stops the investigations. It stops, like you said, the staff get there and the first thing they get is, I've been on the floor for 8 hours. It's very demoralising. So I think that it's only positives. I don't see any negatives in it at all. And just hoping that the rollout plan can be done sort of trust-wide as soon as possible, and then promote it as a positive for the trust nationally as well.
Thank you. Thanks, Nick. Well made. Martin?
Thank you. Yes, I mean, I think this is brilliant. I mean, it's like one or two others have said. I mean, I have very personal experience of this with my parents. What I was a bit surprised to find out, as somebody who didn't know, was in the borough my parents lived in, that the community falls team didn't actually lift anybody. They just wandered along afterwards and sort of said, yes, well, you need a bar there to hold on to. And then I purely accidentally came across something called a rapid response team. So my question is, in the CCAM area, is the sort of infrastructure that's provided by other healthcare providers a sound basis on which to build when you get beyond this pilot stage and extend out? Do you have any sort of wider picture of what land you're walking into, if you like?
Yeah, I guess my vision of what good looks like in the future, and to some degree as well, we don't have a shared understanding of what urgent is and what rapid is. So urgent community response is a sort of 2-hour window, so which is not quick enough for us. So that's why we put in the primary response model, but very much the onward referral is a real opportunity for us to engage at a system level. It may be even that the secondary response bit, so the green response, could be replaced with a direct referral to urgent community response, where the nurses and therapists come out and make that holistic assessment, and we cut out the middleman, for want of a better expression. So there's massive opportunities as planning at system and place level develop, and those community services come on stream. The 100-day challenge, is full of examples of where we should be working together in this sort of way. So yes, it's the short answer to your question. Yeah, there is a vision for how we can do this even better in the future.
Yeah, that's Andy. What I think we suggest we do as well is, if for a board strategy day, we ask you along to actually have exactly that kind of conversation, so we can do some what ifs. So we just think it through, because there's a new NHS structure being developed as we speak, and we do need to think through as a board how we communicate with that structure, particularly with initiatives such as this, when we know we can give benefit to patients. So that's a really, certainly a point that's come across to me anyway, and we'll put that down as an action. I think next question, Lee. Sorry, Linda, rather. Linda, then
I think Linda.
Guys, Linda.
Hello, thank you. Yeah, I was just wondering regarding this service, if there's been any consideration around what Northumbria, for example, are doing to reduce the hospitalisation of such patients, false patients. They've considered introducing an X-ray system that's actually workable in the community, so you can see if there's sort of fractures, breaks to the neck of femur, and whether or not that patient then needs to be converted into the hospital. So it's just whether or not there's some sort of options really within this model or into the future to consider things like that.
So I think the model we've put in gives us lots of opportunity to evolve and to innovate in the future. We are working to a fairly basic, I don't mean that in a pejorative way, but a basic clinical model, which, is the patient's anatomy all facing the right way? Have they got pain? Yeah. And if they have, then we ask for a quick green response. How we then nuance that in the future, again, through community-based rapid response services and stuff, things that you talk about. I think it's all there for evaluation, and as the evidence emerges for that sort of stuff, we can look at it, because we have the infrastructure that could potentially absorb it. So it wouldn't. It's not in the current scope, but the future is what we make it.
Okay, thank you.
Thank you. We get the basics right first. I think what you're saying, Andy. That's a good point. Lee, final question.
My question's probably quite quick. Originally, when this was rolled out, they were the trust, I think, was supplying 2 vehicles for this. Is that still the case, or are the Falls teams using their own vehicles now? Because I had heard rumours that had happened.
There was a proposal prior to this model of care being signed off around using a marked vehicle. In the phase 2, we can look at that again. The difficulty has always been the availability of vehicles to supply, and the own car model, as we call it, has sort of been the one that we've favoured through the project, just to get people out the door in the quickest way. I think there's possibly for some dense population, high volume areas, there may be an opportunity for trust supplied vehicles and a more shift based approach for volunteers. So nothing's off the table, but the first proof of concept is based around own car.
Okay, I mean, I think we can all see the value of it, 100%. Someone did mention to me that they were concerned that carrying the amount of equipment they're potentially going to be required to carry, they wouldn't want to put that in their own car. So I just want to make sure we don't sort of lose any buy-in to the project, as it were.
Yeah,
it's just worth having that on the radar.
Absolutely, it is a challenge. Just a very brief point. This is not a lifting service. It was never intended to be a lifting service, and like I've said to all the CFRs when I've gone to their training, if all you do, and when I say all you do, I mean that in the truest sense, all you do is that human care, reassure the patient, speak to them, keep them warm until an ambulance arrives. That's a huge success. You've addressed many of the risk factors that go with a long lie. So not lifting someone because your car isn't big enough to carry the kit, that in itself doesn't preclude you from being an effective falls responder.
Yeah. Very well said, Andy. I think in summary, if I may, I think from the response you've had from the council members, I think this initiative is really welcomed, and I think people can see not only at a high level it's implementing the trust strategy, which was about making sure we have a flexible response to give the patient the best service, but also it's the humanity that's coming over in the caring elements of this service, rather than leaving people with the occasional welfare call for many hours. And I think we are providing a human response, and the working with the CFRs in particular, I think, is to be commended, and I think is a model we can roll out across the southeast with suitable governance, depending on it's urban or rural. I accept the point you were making there, Andy, as well. So I think there's a really good model here we can use and be proud of, but we can adapt depending on the local circumstance. So in summary, thank you indeed for the presentation. Thank you for the way this has been launched. And I think from a board point of view, from a non-executive point of view, within the concept of Better by Design and the broader change programme, I think we'll be sort of asking the executive appropriately, what's the rollout plan? How are we going to use this in other parts of the area? So we do get some equity as well, because we have the patients don't just fall in Sussex; they fall across the southeast, and we need to do. But it's great that what you've done. So thank you. Great proof of concept. We need to crack on and roll this out further. So thank you.
Thank you again for having me.
Have a good day. Thanks for your time.
Thank you. I'll leave you to it. Have a good day. Bye bye.
Yeah, and in terms of, I may just to bring the meeting to a close with some of the final items, just to make sure that we follow appropriately, we finish appropriately. I'm assuming there are no other items of business, so we need to be aware of. Julie, none being notified. Hopefully the public have managed to remain with us, even though we have gone over time. If there is any public that's other than the participants in the meeting out there online, I'm very happy to take any questions about the business of the meeting. I think the public are represented ably by our governors today, I think. Okay, people have that chance, but obviously, so I hear someone remark. No, let's move on to areas to highlight to non-executive colleagues. Very rich feedback today in the meeting, and I've got a number of headlines, but in no particular order was the issue around the prospects for 2022-23 financial prospects and other challenges facing the NHS. I think what the council is saying to the non-executives, what I was picking up was really, have we got enough money? Have we got enough staff? What we're going to do when we haven't was the broad headline, as it were, and what we're doing around risk management and being planning as best we can in order for 22-23 when the country's in a difficult position post-pandemic. We've got world events going to influence oil price and other things, which is going to have an inflationary impact. It's clearly going to be a challenging year ahead. So that was one of the key items that came across to me. There were risks regarding the vaccination policy, particularly if it was reintroduced and what that be the impact on the service. I think within the patient safety and deep dive, very eloquently explained by Tom, but there's an issue around ensuring that we've got systems in place to, again, as we go into this difficult new financial year, that we've got systems in place, particularly around as we move into better by design and changing the way we work, that we don't get into organisational overload, and we do manage to keep our eye on the key issues. And I think we've also been enthused by the Falls project, Falls programme, and from a non-executive point of view, we're certainly keen to promote that within available resources and to roll that out. Now, non-executive colleagues, are there any other headlines that I've missed there that you feel you wish to promulgate via your committees or via your work holding the executives to account? Anything else we need to be aware of? So I'm not seeing anyone challenging my summary. Thank you. In terms of meeting effectiveness, well, please put your comments on the postcard. They will be well received. I'm sorry about the timekeeping, but I think the important items, we've tried a new format in terms of questions. I think we need to refine that a little bit to get a bigger gap between the questions are posed and they arrive in the inbox of my non-executive colleagues, so they can be I thought they did a superb job in terms of getting the briefing, but they had to do it from 6 o'clock last night to the start of this meeting. So I'd rather get this into a bit more planned time rather than on social hours. So we can look at the meeting schedule, but the idea of written questions seems to work well to me, and hopefully you got some good answers. You got some good answers there. Anything else, Julie, you want to come in and comment?
Just that we have the CQC update and Giles has another meeting at 2:30. So we're just wondering what kind of break the council would like.
Okay. What time is the CQC update meant to start?
In 10 minutes.
Right. So can I respectfully suggest that maybe you have a 15-minute break, maybe start 5 minutes late? Any objections to that? And the CQC, so we want you obviously in the zone about understanding what the CQC process is. This is not about telling you what to say. This is about making sure that you're appropriately briefed in terms of the upcoming visit and your feedback is going to be welcomed by the CQC. Okay, thank you very much indeed. We meet again formally as a council on the 6th of June. So enjoy your 15-minute lunch break.